Good morning. I'd like to call this hearing to order, or reconvene this hearing, rather. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, January 22nd, 2024. The time is 9:32 a.m. Today, we are here to hear the government testimony on the performance of the District of Columbia Department of Health, or DC Health, in FY 2023 and 2024 to date. Last Thursday, we heard testimony from public witnesses on the agency's performance, and we'll be referencing that testimony today. For anyone who was not able to attend that hearing, you can watch it online on the council's website, and you can also still submit written testimony for the record until February 1st at 5 p.m. at dccouncil.gov/hearings. DC Health promotes health, wellness, and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. With almost 715 FTEs, DC Health is organized into 7 administrations and offices: Agency Management Program, Community Health Administration, the Health Emergency Preparedness and Response Administration, the Center for Policy Planning and Evaluation, HIV/AIDS, Hepatitis, STDs, and TB Administration, Health Regulation and Licensing Administration, and the Office of Health Equity. The committee sent written pre-hearing questions to DC Health in early December. And we will reference those materials today. If anyone would like to see them, they're posted also online on the council website at dccouncil.gov/hearings if you just click on the hearing for DC Health. I don't see any of my colleagues here, but there are a number of them in the building today, so I'm sure someone will stop by. But with that, we'll go. The joys of having done public witnesses already is that we can get straight to the government witnesses this morning. And so testifying this morning, we have Dr. Ayanna Bennett from DC, the director of DC Health. Before you begin, Dr. Bennett, I will ask that you or any members of your team who might testify today, I know you are joined by a very large team behind you, I need to swear you all in. So if you can raise your right hand. Great. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. Please begin.
I have found winter and dust are not my friends. Thank you for having us. I want to be very brief because you have more than enough pages of information from us that you really don't need me to say a lot. But I do want to say that I've been here for 6 months, and I really have appreciated this process because while I knew that the people in DC Health were hardworking and passionate about this mission, I did not know every detail of the work that was happening and how much actual success we have had in making things better for the district. I'm hoping you were able to see some of that and that we have a chance to talk about some of it. I will have this very large, very expert leadership team help me with that because they are, of course, the experts on their work. But I look forward to being able to let people know that as dire as things have been over years and as stressed as we have all been, there are some pieces of light in there. Thank you.
I feel like that was the shortest opening statement on record. No. That's okay. We've read it. We have some follow-up questions. And so I don't need to be on a clock yet, but I'll get myself on a clock when we get started. So we'll start at the beginning. All right. So Dr. Bennett, as you noted in your statement, you've been here for about 6 months. The council confirmed you in November, so you had a little bit of period of time where you're sort of on the job training, if you will. Before we jump into agency's performance, I want to revisit some of the overarching themes from your confirmation hearing. At the hearing, you stated that your number one priority was more timely publishing of reports and data. And we'll talk about specific places where we're still seeing some delays, but overall, what actions have you taken thus far as director to improve the timely release of reports and data?
Sorry. We are working right now to try to improve our process of how we get from the staff who are doing the work to the staff who need to approve it. We have a somewhat dense process that I think can be speeded up with a new communications director and a new chief performance officer position that I am just filling, I think at the beginning of March. I'm very confident that we'll get some processes in place. Some of what is being experienced is an inevitable, but maybe not well understood process of data cleaning and data analysis. So much of the data that people are asking for is coming back to us from the CDC after coming from us to them, getting weighted, getting some parts of the analysis, and then coming back to us. That process is taking, and it normally does take, a year sometimes. And so when we are doing the data today, we are working on data that we got back after we end the year. So we want 2022's data. So January 2023, that month is over. Some of that data will not come in right away, depending on what it is.
Mhm.
Some of those appointments have not been scheduled. Some of those lab results maybe haven't come over. So there's even a little drag there. And then it gets compiled and cleaned and sent to the CDC. There's some work done on that data, and then it comes back to us. So that data may not come back until the end of 2023. And that was the 2022 data. And so then we have some analysis and writing to do. So I'm more than happy to talk about shortening and
Mhm.
making efficient the time between when we get a full set of data and when we get that to the CDC, and the time we get it from the CDC and when we analyze it, because there is some work we can do on the data we do have.
Right. So
But in
is
the
the
meantime, we're never going to get it past a certain point.
is the sending of data to the CDC a standard operating?
It is. It's a nationally standard
Okay.
operating procedure, and that is to equalize across the country and to do some of the waiting work that we can't do in the department. We are the single source of truth for the health data for this area.
Okay.
The CDC is the single source of truth for the health data for the nation. Those two things should align. We should not have daylight between the two of us, and that is why there's a long process. And then we want to be sure that we are absolutely accurate. And every piece of data has some errors in it. Every piece of data requires some interpretation to know where those errors are. And so it is just it's a process that takes time.
Okay. I can appreciate that. And we'll get into this more. There are some areas on the DC Health website where the data has
I
not been
know.
updated since 2018. Right. So I can appreciate a year, but it's been like 6.
Yeah.
And so those are some of my
Oh, no,
areas of concern.
I tried to do the research before I took this job. I know that it is not easy to find some of the health data in the department, and some of that is communications.
Okay.
Some of those we actually do have, it just didn't get posted.
Okay.
So I think there are a variety of different ways in which that can be improved. But the year was a fast one. Some of them are a year and a half, some of them are longer.
Yeah.
I don't want to overpromise in that way, but we will shorten the parts that we have control over and be more efficient about how many people need to approve every single thing. I think we are maybe not always efficient in that way.
Okay. One of the other things that I think stood out at the confirmation hearing is we talked a lot about collaboration. And you stated that collaboration is a physical thing, or it needs to be a physical thing. What are some of the ways that you've worked to increase some collaboration among the administrations within DC Health, as well as the other agencies outside of DC Health?
One of the things we're doing internally is setting overarching goals that everybody shares and knows about. So we have department-wide goals. And that's what the chief performance officer is going to help with. And those really push down to administration-specific goals. And then we are enriching maybe our executive meeting process to really talk about those things, to have a little bit more education and best practice sharing between administrations. And I think we've developed some partnerships that will bear some fruit. On the external side, I am just coming to the end of meeting everybody. I have had some just collective meetings with contractors or grantees of ours just to hear what it is they are thinking of. So I met 4 or 5 different food service organizations. I met some of our long-term care organizations. I've met with all of our different industry partners, long-term care, primary care, and the like. And I do think that we have come up with some ideas of things that might be improvements that would be good on both sides. So we're working on it, but I think we will end the year with some specifics.
Okay. DC Health is moving
Yes, we are.
from your location on North Capitol Street. You're moving to Ward 8 next
Mhm.
month. Next month?
February 24th.
All right. So next month. We heard some witness testimony last week where it was a question around whether or not this is an opportunity for DC Health to engage more in the Ward 8 community where you have such a high number of health disparities in comparison to the rest of the city. We heard from the chair of the Ward Health Council, and she hopes that, DC Health will hire more Ward 8 folks from the community or, be a source or a site for food access in some of the areas. Curious whether or not you all, I'm sure you have been focused on sort of the nuts and bolts of a move, but have you had the opportunity to sort of think about what this can mean in terms of your new location around helping the community or your new neighbors rather?
Well, we do think about that, not just me. I think we've all had those thoughts of how that can be a way to operationalize community inclusion that I've been talking about. I think we will do some of that. I don't want to promise it'll happen immediately. I honestly think we are going to have to take a little minute to settle down and unpack. But one of the things I do want to do is be sure that we're in communication with all the existing organized community groups. We have talked about when I might be able to go to the Ward 8 Health Council. We are definitely going to have both positive economic impact, I hope, on the area and be more accessible. Many of the people who use our window services for birth certificates and the like are from that neighborhood. And so it will hopefully make things easier for them. And all of the things that I am looking to do with staff around bringing community in to discuss with things earlier, bringing community in on the design and decision-making stage, that's the community and those surrounding it that we really need to do that with. So I'm hoping it makes us more accessible to people to do those things as a meeting space, as somewhere to convene.
Okay. How long will some of those front faces services be down while you guys move? So vital records, for instance, how long will they be off? Well, offline? I don't know.
So we pack up on Friday.
Okay.
And we unpack on Monday. So they will be down from that Friday through that Monday as they move computer systems and equipment. They will do, are they a little limited the day before?
Yeah.
Yeah, we're going to go down to appointments the day before just to be able to move some of the equipment.
Okay.
So they'll move it in stages. They'll move some of the computers and systems on that Wednesday, Thursday. It's going to take quite some time to move it.
Okay. Just as a suggestion, perhaps you all want to do appointments for that first week, just to allow for your staff to.
Well,
Fully-
everyone's going to be on site. Everyone's going to, yeah. So we're working on it.
Okay, great. And that's going to be publicly communicated to folks. All right, wonderful. All right, let's talk about some of your grants. So overall, DC Health's FY23 grants lapse rate was about 11.7%. That's in comparison to your KPI of about 3%, or at least that's what you hoped for, 3%. DC Health explained the lapse as a result of turnover, vacancies, and underspending by recipients. As the new director, are you concerned of an 11% gap rate?
First, I want to invite Adrena Dean, who is our CFO. Where'd she go? There she is. I'm going to let Keith Fletcher, our Chief Operating Officer, answer this because he's answering it in my ear anyway.
Morning, ma'am.
Morning.
That may have been a draft file you got. We've revised that. It's actually 4.31%. So when that calculation of 11% was done, we in some of the food, the WIC services that we get rebates. And what the rebates do is that the rebates must be applied against the expenditures first. And so what it does when it gets applied against your expenditures, it reduces the difference between what your budget was and what your expenditures are. And if you just report lapses as you typically report local surpluses, I got $10, I spent $8. That's what we did in that original file. We did not account for the rebates costs.
Okay.
So when you make those adjustments, it's actually 4.31%. And that's on a $160 million total grant budget for the year. And we can provide, it seems like you do not have the updated file, so we can send that to you right after.
That would be great.
Absolutely.
Because a 4.3% is very different than 11.
Absolutely.
And okay.
And those lapses tend to be from what we're seeing throughout. It's the CBOs also have the same hiring challenges we have.
Mhm.
And then it's the back end of the same supply chain issues that we're kind of working through now, coming out of.
Okay.
So that's where we are. And that's
Okay.
kind of in line with what, well, our local surplus was a bit less than that, maybe like 1.4%. But
So I can appreciate some of the turnover and the vacancy pieces, but and you guys know this, my biggest frustration is that we don't wait to even write the RFP for a grant until October 1st, even though you have known since May and June that a grant might be available. And so I'm saying that overall, not specifically for DC Health. This is a DC government-wide situation. 4.3 is actually probably the lowest in the health cluster, which is great. Some of your agency sister and don't have a 4.3 lapse rate. Theirs is much higher for a variety of different reasons. But I don't like to give money back. I want to spend it. And so if we can, as we are sort of keeping track of things, I think that's having conversations with grantees about how they're spending their money. For example, okay, so last year during budget, I asked some questions about the Howard Centers of Excellence. And not a lot of you knew what exactly they were doing. So we took a little trim off their budget. And then, of course, Howard started calling. And then we went and we visited. So DC Health has awarded $21 million to the Howard Centers of Excellence over the past 3 fiscal years, of which they have only spent 10 million. 10. When I met Dr. Vincent, he said, "Are you an alum?" I said, "No, but I am a funder." DC government, we are funding part of Howard, and yet they're not spending the money. And so what is the oversight that we're doing to ensure that they are doing what they're supposed to do? Because we've awarded them 21 million, they've only spent 10. We could be perhaps spending that on some other places. So I was particularly impressed with the work that Howard has been doing on sickle cell disease, oral health. Like, we've basically funded a whole new dental clinic over at the School of Dentistry over at Howard, and the hospital-based violence interruption programs, prevention programs that they're doing. So oral health has served over 1,500 individuals in last fiscal year. Sickle cell served about 400 patients. They do some very intense work in trying to bring the cost down. But I noticed that the behavioral health program only served 12 people. Why do we think that happened? Who manages that grant?
As an administration, that's Community Health Administration. And can we switch to get?
while we bring up Shah, just for the record, the Department of Health, the partnerships that we have with our with OCFO and the HR office, we actually have the discussions prior to, we start from the application point. So when we apply for the grant, we have regularly monthly meetings, and so we're managing whether we want to hire staff, add new contracts, expand on contracts that we have. So there's full awareness that if the money comes as we have requested it, that we can make certain moves. There are restrictions around anti-deficiency. So some things you can go as just but so far.
Right.
But we tend to have a very good relationship in that particular space that tends to limit the amount of lapse we have. With respect to grants that we have oversight over, we typically look at them routinely to see where they're spending, where we could move money. Howard Center of Excellence is a little bit different than the typical grant that we have, in that there's a federal appropriation that says the district must give them X. It's 26 million by 2026. And they have allocations per year that we need to give them. So the flexibility that we have to say, you have not spent your 3.142 million, I am going to take 2 million from you, is not the same level of flexibility we have with sub-grantees that we manage, where we can
wait, say more. It's a federal, it's not a federal grant. It's
not, it's a district issued appropriation.
Correct.
And the law that the district issues says that they will get X amount of money in allocations per year. So if we have to change the allocation,
in the
we have
federal,
to revise.
Wait, where, sorry.
So the district appropriation is given to the Howard Centers of Excellence.
Correct.
says that they must get X amount of money at a certain period of time.
Okay.
And in appropriations per year. So when we get a grant that we oversee, we get a tranche of money from the federal government. We have the partners that we want to work with. If they're not being efficient, we can say we will reduce your award. We have that flexibility because we award the grants in our administration. With the Howard Centers of Excellence, while we're overseeing the grant, we do not have the same level of flexibility to say, I'm going to reduce your 3.142 million. Like when we did the cut that you mentioned a couple minutes ago, the 1.697 million, we then had to have a Budget Support Act passed to actually reduce that fund.
Okay.
So that's a slight, we can get.
That's
proper
not as
explanation.
complicated as saying I need Congress to like reduce the
absolutely.
number,
No,
right?
absolutely.
I mean, but I think we have to ask the question, are we getting our full value? So to go back to, sorry, if you could just introduce yourself further. I know who you are, but if you could just introduce yourself for the record.
Robin Diggs Purdue, I'm the Senior Deputy Director of the Community Health Administration.
Okay. So the behavioral health program for Howard Centers of Excellence only served 12 people. What happened there?
They've been having some staffing challenges. We've been working with them, providing technical assistance on their work plans and strategic plans, and there have been some challenges there. What we have done over this past year is looked at some of the centers that have been underspending and trying to reallocate some of those funds to the higher performing centers. So some of the funds were moved from those other areas to support the sickle cell day hospital, which looks to be on track, to open by June 30th.
Okay. Okay, so we've made some adjustments even within FY24.
Yes.
Okay, when we get to the end of when the full contract ends, we don't get our money back, right? Whether or not they spent it. So we're making a donation to Howard University without receiving anything back for it. Are we?
I wouldn't say that. We have till 2026.
Okay.
And we are making some adjustments and doing everything within our power to try to utilize the funds most effectively.
Okay. So between now and March, when we talk about the budget, we need to have a different plan in place around, or request to see from Howard a different plan in place around some of their more underperforming centers. That also being said, I noticed that the description of the FY23 activities for the Women's Health Center overlaps significantly with the description of Howard's activities under its preterm birth reduction initiative grant that's also administered by CHA. And so are we paying Howard double for the same work? Are we paying them for the Centers of Excellence for Women's Health and for the preterm birth initiatives where they're doing the exact same thing for the exact same population of people?
I wouldn't say that, but we are exploring what we need to do differently in that area. The Center of Excellence should not necessarily be implementing some of the activities as they have been, and we're looking at working with them on some of those.
Okay. You just adjust your mic because they're having trouble hearing you.
Is that better?
Yep. Okay. Great. Okay. So I was just to say for the record, some of the things that are overlapping that they've listed on both the community baby shower, which is great, but like we shouldn't double pay for it. Convening a community advisory board. So we're paying for the advisory boards for both grants. And then presenting at the Maternal and Infant Health Summit. So we should just look to streamline there a little bit more if we can. Okay, while we're on maternal health. Okay, the committee had a roundtable in December, and we discussed DC's health need for more updated data in the maternal health realm. And so I was happy to see more recent data that was you all provided in the pre-hearing responses. That said, we noticed a couple of concerning trends that I want to ask about. So severe morbidity for Black women increased from increased to 445 per 10,000 women in 2022 from 323 in 2019. So that's almost a double. Preterm births among Black women increased to 13.6% from 12.4% in 2020. Teenage pregnancy rates are increasing, particularly for Latino residents, from 31.7% to 34.1% in 2021, well above our targets. Given the resources that DC Health is investing in maternal and infant health, are these figures troubling to you all? How are we responding to some of these, particularly around the preterm birth rates, as well as the increase in teenage pregnancy, which we had been seeing a decline in for a very long time?
So I am concerned about all of it. I would say that the maternal morbidity is worse than that because it's actually increased even faster for white women. And the difference between white and Latino women is now almost gone. So something is happening across the board. It's not just a health disparity, it's happening across the board, I think, for all women giving birth in DC. So we have some investigating to do. We have more than sufficient experts and task force to do that. I don't know that we've focused as closely on diagnosing where some of those problems are coming from, but we need to do that. But something is happening across the board. There is positive in the trends where we have made efforts. So where the perinatal quality group has worked, there have been positive trends in terms of how they have impacted morbidity. They have not yet opened up work in every area. So, hypertension, not hemorrhage. So there's room to go on some very common conditions that are causing trouble for mothers. What we need in terms of new work in that area, I think it's not so much that we don't know. I think people have poised themselves to do it. I think we have some room to go in terms of implementation of all of those things and making sure that implementation is across the board. But I'm going to let Deputy Director Diggs Purdue talk.
Sure. Just preconception health is also an area where we need to really do more, right? A lot of our efforts have focused on quality improvement in the hospital setting or prenatal care, but it goes beyond those things. And so we are looking at other initiatives we can implement to really help with health literacy and encouraging the health and wellness of mothers before they become pregnant.
Yeah. I will say that I think some of the things, to your point, Dr. Bennett, that you talked about, there are some things that are working. So, I was impressed by the results that were reported by the Perinatal Quality Collaborative, which is run through the DC Hospital Association through a DC Health grant. Before the PQC conducted its trainings for staff at the 5 birthing hospitals, 36% of women received timely treatment for severe persistent hypertension. And then after the trainings, 85% of women received timely treatment. So something is working here in terms of the, I don't know if it's because we picked one issue and then we focused attention on that one issue to bring that down, as opposed to saying, we need to fix all the things.
That is why.
Okay.
That's what quality improvement is. It's getting everybody on the same page so that we actually fix the thing. What needs to happen now is that those best practices need to be monitored, but not necessarily the focus anymore. And I think their next target is hemorrhage, right? Which is a huge part of what maternal morbidity is about. So we're just going to have to pick up a problem and try to solve it. Part of what's happened just across, I'd say across the field, is that there are new interventions. There's been a lot of work in this space, both just by obstetrics as a field, but also by different states in terms of how do we respond to some of these. There's been a lot of work in hemorrhage in, say, California or other states, bringing those best practices so that those are the practices that every doctor is using does take some time. People have their habits of practice.
Mhm.
And so needing some focus to say, actually, the thing that you've done is not working. Please do this other thing, and actually getting on top of people to really be sure that they did that. It is intensive work because you really do have to monitor on a very close level,
Right.
but it is working when it works.
Okay, so let's talk about something that I don't know if it's working. You guys tell me. So I noticed that in several of the DC Health Preterm Birth Initiative grantees, they use the Mommy app, MAHMEE. Yeah, okay. To keep track of patients' health. So I'm a little concerned here in terms of like if we are evaluating whether or not this app is actually effective. So in FY22, DC Health reported that the company behind Mommy provided unsatisfactory performance on the $650,000 grant to integrate electronic health records. They only reached about 637 people out of the 10,000 who were supposed to be targeted. What went wrong with this grant, and why is DC Health continuing to invest in it if it hasn't been working?
So we gave our grantees choice. So as part of their grant agreements, they were allowed to select an electronic platform that they felt would best meet their needs and for their patient population. Some of them work with baby scripts. Some of them chose to try to work with Mommy. And so we're in the evaluation phase to see how that's working.
Okay, so when will you have outcomes in terms of, like, I'm all about providing choice, but if we're providing choice for a bad product, then what are we doing?
Yeah. I mean, previously, when we were trying to dictate the platform to use, that wasn't working either.
Okay.
So, this is our attempt to say, okay, if you all want to try to choose something that you feel will work best within your system, let's see how that works. So we are evaluating, and so we should have, results to make future determinations this fiscal year.
So we're gonna keep with it through FY24 and then reevaluate.
Yes.
Okay.
I mean, we're evaluating through along the way.
Okay, but you won't make a determination until FY25.
So we do plan for our grants prior to the new fiscal year starting, right?
Okay.
So that will be taken into consideration this spring as we're working on our RFAs for FY25.
Okay. We've been joined by Councilmember Zachary Parker from Ward 5, who's a member of this committee. Ashley, if you could just put me on a 6-minute clock so I could just wrap up these and then we'll let the council member here ask some questions. In the CPPE's pre-hearing responses, they report that the perinatal health and infant mortality report for 2021 to 2022 is now anticipated to be released in April of 2024. They go on to state that they need 5 statisticians to release reports in a more timely manner, and that you only have 2. Is it you have the 5 positions and you only have 2 people hired, or you need 3 more people?
I'm gonna let speak. I'm gonna let Senior Deputy, come on, Johnson Clark, come up. But I will say before she speaks that we went through what almost every health department at both a state and federal level, and even the local level went through, which was a lot of turnover in positions and the loss of positions that were brought in for COVID, somewhat became integrated into other pieces of work, and then now are going away. So there has been a lot of disruption in this area of the department because it was so integrated into COVID, but I do believe that there's some efficiencies and organization that's been planned that I think we can look to improving what we feel like we need in any one thing. And some of our process around how these things get written and approved is again needing some improvement. So we will make changes, but even with that, I think there's something to be said about the staffing. Go ahead.
Okay.
So good morning. I'm Fern Johnson Clark. I'm the Senior Deputy Director for the Center for Policy Planning and Evaluation. So prior to COVID, we built a team. We had 5 statisticians because we made an assessment that we needed that many. They were actually, when I came into this role, There were many more, I think up to 10, and there was reorganization, and the determination was to reduce it to 5. So we built the team to 5, and we also hired a data analyst. During COVID, there was a lot of transition. So we lost a lot of the statisticians for various reasons. Some wanted to relocate where close to family. And then also some took the opportunity of taking jobs where they could telework 100% because that was demonstrated that they didn't need to be physically in the office.
Mhm.
So we have been recruiting very strenuously with our associations, LinkedIn, and everywhere that we can find to recruit. And we have not been successful in filling those numbers. However, we have one statistician who should be coming on at the end of January
Okay.
and 2 data analysts at the end of January.
Okay.
So,
So my question was, this wasn't a case of you need additional FTEs. It's that you have FTEs, but you just need to recruit for those positions.
correct.
Okay, wonderful. So you all said that in the interim, you have created dashboards to provide more timely information. How can we find those dashboards?
So those dashboards are on the DC Health website, and it's under services. As I know, it's very,
How about you just send us a link?
we can send you a link.
Great. Okay. I have questions for the head of Octo about the state of everybody's websites, but that's not you guys. But if you could just send us a link, that would be helpful to sort of understand on that front. Okay, at last year's performance oversight hearing, DC Health testified that it would complete its development of a licensing process for certified professional midwives and doulas in FY 2023. What is the timeline for final regulations on these professions? Where's Aisha?
I'm gonna let the expert take this one.
Good morning, everyone.
Good morning.
So the goal is that they will be completed in FY '24. One of the things that needed to be accomplished was the recruitment and appointments to the advisory committee, which is the Maternal Healthcare Professional Advisory Committee, which is now staffed. They've been meeting. We do have draft regulations for both professions that was completed prior to the full committee coming together. And now the goal is that they'll be reviewing it to go before the board so that the board could do the final approval. Another thing that the board was holding out for was the appointment of a OBGYN to the board, which Dr. Gorman was confirmed by council and will be joining the board at their first board meeting for the new year, January 31st.
Okay, so you said completed by FY 24. FY 24 goes until September 30.
So
Give me an estimate? Is it spring? Is it summer?
I'm gonna say it's gonna be the summer.
Okay.
The timeline is, again, we do have a draft. During the pandemic, we were fortunate enough to get someone detailed to us who was a certified professional midwife. Oh, no, she was a doula. So she worked with our legal team to help draft the regulations. But we want to have individuals that are part of the community, subject matter experts, review what's been done, emphasize or add to it if needed before it goes to the board.
Okay, great. I am at time. We're gonna do 12-minute rounds. You need more time? Okay, all right, then you let me know? Okay, great. Okay, so let's keep going. Okay, at the maternal health roundtable, we discussed a new blood test for pregnant women with hypertension that can predict development of severe preeclampsia. I understand that it's I wouldn't call it an expensive machine because like in the $19 billion budget realm, it's actually not that expensive, but nonetheless. Does DC Health believe that purchasing these machines for the 5 birthing hospitals would be a worthwhile investment in terms of outcomes?
I'm gonna ask the senior deputy for that area to come up. That would be you. Where'd you go? If you want to delegate that to the expert in that area, that's okay. You have a lot of experts.
No, that's great. That's how we get answers. If you just introduce yourself for the record.
Hello, hi, my name is Dr. Kapuli. I'm the Family Health Bureau Chief at the Community Health Administration at DC Health.
Great. Oh wait, I think you were supposed to be at the hearing and then you had an emergency.
I came to the hearing. I had to, yeah.
Oh, sorry. Someone had it. Yes, you were at the hearing. Okay, sorry. So you heard a little bit of the testimony in the back and forth that we had with some of the doctors around the blood test machine. Do we feel like this would be a worthwhile investment?
I believe so. This is something that we're currently looking into.
Okay.
And so from the maternal health roundtable, our team is currently working with our various partners and grantees to see how we can make that possible.
Okay. At the roundtable also, we discussed the need to streamline the number of task force and commissions on maternal health. But then DC Health later reported that CHA is creating a new maternal health task force that will be evaluating and streamlining the consolidation of 11 maternal health subcommittees. So like you're creating another task force to streamline and consolidate the task force. Did I read that right?
So, so we actually met internally right after the maternal health roundtable based off the recommendations that you provided. And so we collectively came as an agency, reviewed the various committees, advisory boards, working groups, task force, just to see what buckets are all of them covering. And so we're actually meeting this week internally to kind of do a little bit more of a deep dive to see that any new boards that we are creating or any task force is necessary. But we do have a bit of federal funds that will allow us to give us that flexibility to do more work around that.
Okay, great. So I also would encourage you guys to reach out to Department of Healthcare Finance because they also have a maternal health
Yes.
task force. So if everybody could just be swimming together.
I will say though, we're going to have to get representatives from all of those different groups together to figure out how to do this. So there will have to be some kind of task force to figure out what to stand down, what to merge, because we need their expertise into which of these things are the same thing.
Okay,
And which of them are meant to do different things. So they are not exactly the same. They're all slight shades of the same problem. But I do think we're going to need their expertise in making that decision. So there's going to have to be some kind of collaboration.
okay, great. Good. Well, we'll follow up in March and just kind of see. There's another commission. I'm trying to find the question. I can't remember. Here we go. Yes. The Commission on Health Equity. Okay, so DC Health reports that the Commission on Health Equity did not meet in FY23 or in FY24 and describes the challenges as MOTA not moving on nominations suggested by DC Health as far back as 2020. Now, I'm not going to say anything about MOTA. We're gonna stay focused. Does DC Health still see value in convening this commission, considering they have not met in over almost 2 years?
I'm going to say something brief and then let Dr. Arno, who's our director on the Office of Health Equity, speak. Health equity is going to be a complex issue for whatever problem we pick. When we talk about those social determinants and key drivers, it insists that there be people who maybe don't think of this as their issue. So if you're talking about housing or other things, health equity is maybe not the way they describe what they do. So we will have to bring people back together if we're planning to do anything. Whether or not this is the group, we can maybe have a discussion about. I'll let Dr. Arno decide what she wants to recommend on that.
Okay.
But we will have to come back together. Coming back together as a general kind of space to speak is one way to do it. Coming back together around specific problems is probably more effective. So we'll just figure out which of those we're doing.
Okay.
But I do want to let.
So
you know.
I'm asking this because this particular commission requires nominee from the mayor to be approved by the council. So we have to hold a hearing and do all of these different pieces. And so my understanding is that this commission doesn't currently have quorum to even meet. Should we be pushing for more nominees? Should we wait?
We have been pushing, sorry, I should.
No, your mic is on, Dr. Arno.
Yes, good morning. For the record, my name is Anita Arno, Director of the Office for Health Equity. We had planned to have a really robust set of policies and discussion with the commission. And there had been a valiant effort put forward to try to reconvene it with the right range of folks participating. If you look at the legislation that created the commission, it requires a broad range of folks who are not only representative of the healthcare space, but a broad range. What we did end up with is a situation where we did not have a chair. That happened at the very beginning of FY23. And that was a known issue coming down the pike. So that was the reason for us trying really hard to get the folks to the table with the range of capacities and expertise to make it happen. But it did not happen.
How many people are supposed to be on this commission?
There's supposed to be a total of 9 voting members.
And how many currently, technically?
Technically, we have about 2. And one, in fact, everybody's term currently has expired.
Okay, so they are holdover, sort of.
Holdover, sort of. And some people have actually resigned from the board.
Okay,
I will say, I do think we need to have some creativity about bringing people together, that we don't necessarily have to have formal commissions to have a conversation. And that sometimes having a shorter, more focused conversation, we're going to meet 3 times and come to a decision, for example, might actually work better than kind of ongoing commissions that don't necessarily have that time pressure. If we don't make decisions, we don't do anything, and just talking to each other is not really usually that helpful unless it's a problem we don't understand. That's not true for most of these.
okay. Well, we sit on a commission that I wish had some time structure to it as well. Okay, so how about this? If you guys could think about what you want the future of this to be, Dr. Arno, this is in your bailiwick. My understanding is that they're supposed to be advising your office on the activities and work that you've been doing. Clearly, you've been doing work, so without this, but I don't want to sunset a commission and then have the public think, oh, well, the government doesn't care about health equity. Health equity is embedded into everything that we do. But we need to have a conversation about whether or not this is the right form, to your point, Dr. Bennett. That will require legislative change. So that's why I'm asking you guys to take some time and think about how you want to proceed on this. This committee has moved quite a bit of nominations that are in the DC health space. So that's not a concern for us, but it is a concern that I have a commission that people ask me about, and that commission hasn't met because the commission has no people. So we just kind of need to work through that. Good? All right. Councilmember Parker?
My computer is still loading, but I'm ready. I'll jump in.
Okay, great.
Okay. Good morning. I will start from last year's report on, and I forget the name of the report, my apologies, but about the increase in HIV and sexually transmitted diseases that proceeded from the previous year. In last year's oversight hearing, this was a point of concern and questioning for me, and we discussed targeted outreach that the department and the agency was going to conduct across the city, as well as making more testing available. So can you just give an update where we stand currently?
Sure. So we have, good morning.
Good morning.
I'm Clover Barnes. I'm the Senior Deputy Director for HOSTA. And we have done a tremendous amount of outreach over the past year targeted at specific communities of focus who see an increase of HIV. They're same gender loving men of color, young same gender loving men, Black women. We've done some things around Latino men and women. And so we have done, we have a group of community engagement staff who convene quarterly to plan out activities. Our next activity is for Black HIV/AIDS Awareness Day, which is next month. It is targeted at college age or young African-American men and women who we've seen hold a significant burden in new HIV
And
infections.
how many people are on that convening that are getting together quarterly?
There are 7 people on the committee that represent all the different factions. They're same gender loving men. We have a lesbian woman. We have a Latina, a group
Okay.
of people who get together.
And in terms of rates, and I wish I could reference this, where are we today versus this point last year in terms of rates? Of
HIV rates?
HIV rates and other sexually transmitted diseases.
Yep, so our HIV rate is going down, not as rapidly as we needed to, but it is going down, which is a good point. We still see significant rates of STIs, of gonorrhea, chlamydia, and syphilis in the city. We are making strides on those as well, but we definitely have work to do there.
And I would venture to guess that rates are going up in socioeconomically depressed areas of the city. Is that accurate?
What's interesting is our gonorrhea rates actually have been up in like Ward 4 and 6 and not necessarily in where you would typically like to or expect to see, not like to see, expect to see. Yeah, sorry, that was a mistake. Expect to see the rates going up.
Okay.
So, I mean, STIs don't discriminate. Anybody who's having sex can get one, so.
Can you, as a follow-up here, share more information as that convening is getting together quarterly with the committee and myself? I would be interested in following up. I wanted to switch gears and switch to school nursing. And this was a conversation we recently had. From talking to the charter school board, it sounds like schools can only qualify to get nursing professionals if they have a school health suite. And we
Yes.
talked about that before. And for those schools that may be occupying an office building or some type of facility that doesn't allow for that health suite, what coverage or support does the agency provide to these schools?
So if they are not part of our school health services program, they have the option of still receiving technical assistance from us. So the AOM training, they can also utilize our school health management system. And that's what we have right now.
Okay. And looking at the answer to question 47 and the 3 questions that were sent over by the committee, all of the schools in the city that don't have nurses are charter schools. And so it begs the question, is there any oversight? So right now that is a loophole, that there is no oversight or requirement that the agency has to ensure that these schools have nursing professionals.
Not directly through us.
No. The adequacy or mix of services that they need at the school would be an OSSI purview. The quality of them, if they have them, would be ours. So it's a partnership there, but we
So to
don't
that
determine whether they
point,
have it or not.
if you all are surveying the schools that have them versus don't have them, can you walk me through how are you assessing the quality of a nurse that is at a school that is not participating in the nurse program? So if a charter school, let's say, is not participating because they don't have a health suite, they contract with an external provider, how is the Department of Health assessing quality of that nursing?
So we do some part of the quality assessment of all nurses. So we license them, we follow up on complaints and investigate if there's some reason to believe that they've had an error or committed some infraction. So they are in the community of nurses that we oversee, but we don't do a special investigation of them as a school nurse.
And one more question here. I know another loophole seems to be there isn't a requirement, whether it be a nurse or a practitioner. As I know in the Department of Health's program, you all are working on a cluster model. So even though every school may not have a nurse, there is a nurse that is advising, overseeing, and coordinating with practitioners that may be at different schools. If I am a charter school, I don't have a health suite, I'm contracting out, are you assessing, documenting which of those schools even have nurses versus, I don't want to say sub practitioners, but others that are not nurses that are filling in that role?
Again, no, we don't have a
Okay.
role in OSSI's oversight of those schools.
Okay. I'm skipping ahead. I want to come back, and I'm going to have more robust questions in 1 second when my computer turns back on. To follow up on the hearing we had regarding maternal mortality in the city. There were a few questions that I posed and the agency was supposed to follow up, and I will just ask some follow-up questions now just to see what has happened since that date. So one was around the maternal health summit that the agency participates in annually. And it's my understanding that the agency oversees that summit. Is that accurate? No. What role does the agency play in the planning of that summit?
So I played I'd say advisory technical assistance role with the folks who were doing it, which is the Office of Community Relations, I believe, CR. Someone will correct me on that.
Okay.
Mayor's Office of Community Relations. Oh, good. I got that one right. I spoke to them multiple times about what kinds of things we might do, but they developed a plan themselves and they executed it themselves. I just had a role in advising about what that might include.
And while it may seem trivial, one of the things we discussed is how do we get the summit actually in communities most impacted by maternal mortality, i.e. Ward 7 and 8? Do you have any insight whether a decision has been made on the location of the next summit?
I don't.
Okay. We also talked about the allocation and distribution of support services throughout the city. One of the things that repeatedly came up was ensuring that there were more urgent care facilities in wards, predominantly east of the river. Can you just share updates from the agency's perspective of how you're working to distribute resources or get care closer to expecting moms?
Well, the new hospital will have a significant impact because it will have a birthing suite. The plan about where services are, I think, is a key part of our healthcare facilities plan, which SHPTA does, which is ongoing. That should come out this fiscal year, I believe. Correct me if I'm wrong. So that is part of a larger assessment of where services of all kinds are. So we've had some conversations with primary care and others about whether or not the hospital suites are going to be a significant part of the birthing plan for that community, and they will have to go other places because they do have more births than are going to be handled in that space. But I do think it'll have an impact. I think we'll have to see what that impact is.
Okay. I am going to yield back the remainder of my time for this round, and I'll be ready for the next round. Thank you.
Thank you. It's always fun to do these hearings with other people because y'all get tired of hearing me talk. Okay. If Director Barnes can come back, I do have some questions about HOSTA. Okay. All right. So HOSTA leads the agency's work on STI testing and education for youth. In FY23, you all and OSSI collaborated to convene the Youth Advisory Board of 15 youth representing 5 schools. My understanding is that these youth created a 6-hour training on STIs. Yes?
Yes.
All right. So how is this being made available to schools and young people?
So the team goes into schools where they are welcomed and allowed. That
Okay.
has to be.
That feels loaded. and layered.
Well, they can't just walk into a school.
Oh, yeah,
right? And
okay.
since COVID, it has been a different process
Okay,
to get into schools for different activities. And so sometimes it's like when they have like a health fair type thing, sometimes they're like, yes, please come in during the day. We'll have you here from this time. It's just varied significantly since compared to the way it was before COVID.
okay, so in FY 23, you all created the training. How many outings happened?
I have to get back to you on a specific number.
Okay,
I believe it's in our response though.
Okay. So what's the plans for FY 24 and beyond?
So we have our youth advisory board. We are continuing to get into schools
Okay,
and make those connections. We are continuing to grow the team. Right now, we're not at 15 students. We trained 16. We have about 9 that have continued consistently.
okay,
And so we're working to get back up. We found that the students have competing priorities with after-school activities and some of them needing extra support for school in that transition to high school and those kind of things. And so we are working to recruit those extra 6 kids that we need to participate, but they are continuing to get out the curriculum. What they do is they recruit from their circles of friends.
okay.
And so-
Do we pay?
Yes, we do.
Okay, so this is like, this could be your job. Well,
Yes. It's
a
their
job.
It's a job for them.
a job.
And so they are compensated for holding trainings. They're compensated for completing trainings themselves. They're compensated for social media posts,
Okay,
that kind of thing, so that they're engaging their social groups in their forums that they participate in on Locket and,
Mhm.
Instagram and TikTok and all that kind of stuff that they participate in.
I know, and this group of students is focused on the STI piece of it, but I feel like this group of students could also be very helpful as we think about opioids and good, just overall healthy, don't engage in
Youth
risky
stuff.
behaviors type of
mhm.
stuff. Thoughts on that? I know that's kind of that's outside of your wheelhouse in the HOSTA sense, but when we
Yeah.
think about talking to young people,
Well,
and you
they're
already
very-
have a captured group, why can't we double dip and use them more?
I think we tried to set the base with the STI stuff because we were restarting it. Like
Oh.
this is the first time we had it since pre-COVID.
Okay,
But we are looking at how we can make sure that they're doing their best to be whole person centered
okay,
in what they're doing when they go.
great. All right. So HOSTA leads STI testing at schools. In FY 23, you conducted testing at 4 high schools, reaching a total of 173 students. How were these 4 schools selected?
Like I said, the people who basically would let us in and were supportive of partnering.
Okay.
Mhm.
I wonder though, to what extent, I think sometimes for school leaders, like they're very focused on like, I've got to meet the academic stuff,
Mhm.
not really, and they may have a full understanding of like why you're asking to come do STI testing,
Mhm.
where hey, you guys can't share specific information about students, but let's say you've had 15 pops from the same school, perhaps somebody needs to talk to that group of young people about keeping their hands to themselves, right? Like, or, doing something.
Yes.
But if the school leader doesn't know,
Mhm.
so are those types of conversations happening around
They
like,
are. And actually, I've been having a bunch of them myself. I'm gonna be honest. I started with my own children's school. One of them goes to high school in Ward 5.
okay,
And we just got in there to start doing testing.
okay,
So we are doing those conversations. And so as we are able to get in and meet with the school leaders, a lot of time it's ancillary staff who are the counselors or supporters who know that these things are happening with the kids more than the principal, that we've been able to liaise with and build better connections. But that's happening.
okay.
I feel it's like in a positive trend. It's not a negative, right?
I think also using the school-based health centers, because they're there,
Mhm.
and I think we pay for those. Y'all pay for,
Yes.
yeah.
And we have been partnering with them in
Yeah.
conjunction with CHA. They do
Okay.
testing. Mhm.
Great. So I think I talked to you a little bit about last week at the performance oversight hearings with children's, but like the numbers for Baloo and Dunbar look very different than the numbers for the other 5 high schools in terms of getting students into those health centers and then the work that they're doing there. And so, to the extent that you and Robin can sort of like lean in on the children's work of, hey, I don't know what y'all are doing, but like, you only had 12 students, whereas, Cardozo had 190, like, we need to sort of get those numbers up. I think that certainly help there. Okay, DC Health underspent on its housing opportunities for persons with AIDS federal grant, just spending roughly $11 million out of 25 million over 3 years. What led to this underspending?
So the way that the HOPWA grant works is that you have 3 years to spend the initial year's budget. So if you got the money for FY23, you can spend it for that year and then 2 years after that. So it's kind of a rolling budget.
Okay.
It's not to the same extent of underspending as a traditional grant. And so we spend every year's money down to nothing.
Okay.
We have to do first in, first out. So it may look like this year's money is still sitting there because we may be spending what's left from last year or the year before, if there's a little bit left from that.
Okay.
But it's first in, first out, and it's good for 3 years.
And what kind of things can we spend with this? Like, what type of activities can come under this grant?
So we pay for tenant-based rental assistance, which you see in the response. We pay for short-term mortgage and utility assistance. We call that STRUMU. Like basically if somebody's behind or they need help with their utilities, that kind of thing. And then we can help with first month's rent and security deposits for people who are moving into new homes.
Okay. So overall, we noticed some very low numbers for individuals served by several HOSTA housing programs. So 10 people served in the Transitional Opportunity Program, 10 people served in the Senior Transitional Opportunity Program, 8 people served in the PrEP housing, for example. Is this by design or is there like, by that, I mean, is this not considered low? Is this considered the amount for the amount of money that we have? Or are there more people that we can serve and there was a challenge in doing so?
Those are our goal numbers.
These are the
actually.
goal numbers.
They are not really high. What we do, the tenant-based rental assistant has a little under 400, 380 clients in it. And as rents go up and as people need more assistance, we have found that we need to use, what we do is we use the money that's not spent on TBRA or STRUMU to fund those other programs so that we're trying to help people in some sort of way, because we can't sustain another lifelong subsidy for HOPWA. Does that make sense? So tenant-based rental assistance, we can't really kick people off.
Right.
So when people move out for attrition, if we don't use that money up in the increase in rent for each year, then we use that money to fund some of those other rent subsidies. Some are shallow rent subsidies, some are senior programs. And there are ways that we can help people in a shorter amount of time that isn't a lifelong entitlement, but still helps people get housed and be stably housed.
How do you all identify individuals for the program?
They are all taken in through a central point of intake, the same central point of intake the city's other housing programs use. And so what they do is evaluate which programs they're
Eligible for, and then kind of
Correct.
plug. Okay,
Yeah.
great. So to date, DC Health has not released HIV data for calendar year 2022, which means that the last citywide data released is available from 2021. We have seen DC Health be able to provide real-time data under certain circumstances. So COVID, gunshot data. What's the delay here? Is this it's with the CDC and we're waiting?
So that's part of it, but I feel like the comparison to COVID is unrealistic. And so COVID, 90% of the people in the health department were working on COVID, and we had extra staff that were paid for by COVID funds.
Okay.
Now that everybody's back where they're supposed to be, and we're getting staff back up, we're getting to the point where we can release data. Hopefully, our goal is to actually put out data more consistently than what we do, and to do it quarterly, like maybe 1 quarter behind from where we are. And our goal is to start doing that this summer. But the data from 2022 is complete. We are working it through the approval process and it'll be released. Our goal is for Black HIV/AIDS Awareness Day next month.
Oh, well, that's a nice, okay. That's a good release. Okay. DC's automatic inmate HIV/AIDS testing and counseling program launched in 2006. so it helped to ensure DC residents were tested and provided treatment for HIV while incarcerated. Recently, the Washington Council of Lawyers brought lawsuit against DC Department of Corrections, alleging that they were treating inmates differently based on medical conditions, including HIV. And so what's DC Health's plan to ensure that the HIV and testing remain available, but not used against an inmate?
So it's difficult. When they come to the health part, we don't disclose necessarily what they're coming for, but it's known that they've come to get the health screening. So I'm gonna be honest, I'm not sure how they find out that they were there for HIV specifically,
Okay.
or if they're just discriminating because they came to the health suite for something and maybe they come consistently, so they know that there's something going on with them. So I will do more research on that and be able to give you more.
Okay. If you all can, this is part of the collaboration piece, and you gotta sort of go check in with Department of Corrections to say, like, can we just talk about this? Because it is a lawsuit. We're not admitting that something happened here, but there's clearly an alleged complaint that we need to figure out what's happening here. Okay. Okay. He'll be back. I'll keep going. All right. Okay. I'm trying to pick something short so that, when he gets back. Okay. Okay, let's talk about facility licensing and inspections. All right, so SHPTA reported that 6 facilities have not yet reported their uncompensated care requirements for calendar year 2022, and that 2 other hospitals did not meet the required levels of uncompensated care in 2022. How does DC Health collect this information from the hospitals, and what are the consequences if a hospital does not report?
There she.
Good morning.
So,
If you just introduce yourself for the
I'm-
record.
yes, my name's Terry Thompson. I'm the Director for State Health Planning and Development Agency, better known as SHPTA. So, hospitals self-report. We have a form that they complete. They are provided the form every year with a reminder to complete it. Some are faster at it than others. We actually will provide an update. I think at this point we have all but 2
Okay.
hospitals having completed the uncompensated care report.
Okay, so what are the consequences for not reporting?
So if we get non-compliance completely, we do have the authority for civil fines. We have not had a circumstance where we've needed to use that kind of a sledgehammer. Usually we can just help them along the way. It's usually a technical issue.
Okay. I think given how arduous the process is to get a CON, I'm surprised that we provide this level of flexibility for folks to report or not report, especially since we're talking about calendar year 2022, right? So that means that they have gone over a year without responding to perhaps your repeated emails or phone calls to their institutions about, hey, where's this information? Like, why wouldn't someone want to report this?
So the 2 hospitals that we're waiting for additional information on is because there were some technical issues.
Okay. Okay.
So it's not a full non-compliance. We don't want to give you the information. We need to make sure that the information that we receive is accurate and complete.
Okay. So I have information that says that, yes, you had someone who didn't respond, but then that there were 2 hospitals who didn't meet the required levels of uncompensated care.
So we do have hospitals that their obligation has not yet been met. They then are required to give us a report on how they're going to remedy the delta,
Okay.
right? And work towards meeting the future obligations.
Okay. At the end of, well, not the end, at last year's oversight hearing, DC Health testified that there would be a CON online application process by the end of FY 2023. Was this completed?
So we do have an online process. We are now completing so there are some components where the application requires an upload. We're now working through having that as an online fill in the blank so that will have better information to generate reports.
Okay. So I can submit my form online.
So you can submit the information online. We're just improving the process.
Okay. All right. Okay, so let's talk about food inspections. Thank you, Director Thompson.
While we're waiting for one of my other experts to come up, I just want to make, this is a good point on data. So it takes as much as 90 days or more to be sure that the billing that went out in December, November, October actually is completed, that the insurance is going to pay it or not, that the person is going to pay it or not, that that's debt you can write off. So it's not really a year. It's probably at least 4 months, maybe less than that, just because the process is slow.
Okay. That's helpful. I think people just want it when they want it. And usually it's when you're looking for it and you can't find it, that's the issue. Okay, so food. I'm just gonna read off a few of the deficiencies that were found at DC Jail during DC Health's April 2023 inspection of its culinary facilities. So gnats were observed in the preparation area. The refrigeration units were dirty. The freezer door did not close. Equipment not sanitarily maintained, including the bread mixer, the meat slicer, the buffalo mixer, ovens, ice machine, and food trucks. Given these stark deficiencies, I'm surprised that DC Health only conducted one more inspection of that facility that year, so last year. How many inspections is DC Health required to do of the jail every year?
So we do three per year. It's important, it's important to note that with these inspections, we do an educational component too. So even though we are technically regulatory, we do have a heavy educational component with the jail on trying to teach them the right way and give them recommendations as well.
Okay. But you're supposed to do 3, and so technically you only did 2. Is that accurate?
Correct. Yes, that's correct.
Okay. So what happened? Is this a staffing situation?
So it's a combination of things. So essentially, we have a lot of complaints that come up throughout the year. So we spend a lot of facilities, we spend a lot of time going back. So what we see is some facilities we may not get to, but other facilities we're in several times a year.
Okay. DC Health says it has no enforcement authority over the DC jail facilities. And so who do you all talk to when you're communicating about the deficiencies? I believe that they have a contractor, so it's not DC Department of Corrections who is preparing food in-house. So they have a contract, which means that their contract is not performing if there are this list of deficiencies. But I'm trying to get an understanding of what level DC Health is saying to Director Faust and DOC, this is a problem and you all need to address it.
So we do conduct exit interviews at each one where we go over the information, and then we also send the information to the jail, send a survey report to the jail at the end of the write-up.
Is it going to the director himself?
Yeah.
Good morning.
Morning.
My name is Renata Cooper. I'm the Associate Director for Office of Health Facilities. So interestingly enough, the DC jail inspections are not conducted solely by the food division. Staff from the Office of Health Facilities are conducting those inspections. And so they are sanitarians. And this year, we actually transitioned in that work because we were previously using a contract employee. However, due to their unavailability, at times. We then had to use our actual staff that we have that actually conduct the inspections in the other health facilities throughout the district as well.
Okay.
That is partially why we were only able to get 2 inspections done this year.
Okay. Of the inspections that are sort of required across the board, so of the health facilities, schools, restaurants, et cetera, how much contract labor are we using?
That is it.
So just for the jail?
Mhm.
Okay, so for everything else, it's DC Health staff who is going out and doing. Okay. All right, so for food establishments, well, let me back up. Let me just close the gap here. So I sit on the Judiciary Committee, even though I chair this committee. And DOC will have its hearing coming up, and I'm going to ask questions about this. This is why I'm asking you guys to try to understand, are you fully communicating, not just with the contractor, but with the actual agency of the issues within its facility? Because if you have, then they are now responsible for responding to the agency who said, your bread mixer is dirty, right? Like, if it's only coming through the contractor and then they're not getting all of the information all the way up, then they can say, oh, we didn't know. So that's why I'm asking, like, was the senior administration of DOC informed of the issues?
Yes, the reports are sent directly to Director Faust and his regulatory compliance employee, and
Okay.
that's usually who we contact with in regards to conducting the inspections and send the information to her as well. She's also a part of the exit conferences, and
Okay.
the wardens are present as well.
Okay, great.
I think it's also important to note, similar to our other inspections that we do at health facilities, our reports will report only the negatives, right? That's the whole purpose of why we're there. At times, there are things that are corrected on site while we were, like, if we observe something and they correct it right away. However, our reports will not reflect that because we found it. If that makes
Okay.
any sense. Like, we walked in, and unless they had just done some type of dining service, and then it's understandable why something may be dirty. However, if we found something and then they corrected at that time, they know that they've corrected it, but we still have to report it on our document.
Okay. Is there not a way to update your document to say and correct it on site?
That is just not the customary way that we document our findings, is that
Okay.
we document what's wrong, and then they will document in their way any corrections that they would make, or to Director Faust.
Usually we want a plan of correction, like what's the system you're building that will make this happen, not just. it
The
was
one
dirty and
time.
you
Yes,
cleaned it.
yes.
So that's the reason not to take stuff off just because it looked okay.
Oh, no, I don't want to say take it off, but I do the notation of that around, we could see your report. I don't know if the public will also see what they did in response. Does that make sense?
Yes, I understand that.
Okay. Okay, so for food establishments, I was happy to see that the number of routine inspections went up. Yay, because that was last year's hearing. As well as the complaint inspections, fines, fees, et cetera. However, still, only about 38% of our food establishments are receiving their routine required annual inspection. Which I think is a problem. How do you all feel about that?
Yes. So
Yeah.
Yes, so ideally, we would like to get in every food establishment at least once a year, but that's why we follow the FDA model and use the risk factor, because there is a shortage of sanitarians. And so like we discussed last year, we used the risk factor model, risk level 1 through 5. 5 tends to be like the hospitals, serving highly susceptible populations, and ones tend to be prepackaged foods such as gas stations. So everywhere in between.
Okay. All right. So the committee provided DCL with 3 additional positions for the food division in the FY24 budget. Are you guys currently recruiting and hiring for those positions?
Yes, we are. So we are currently, actually this week, we are conducting interviews for 2 of those positions.
Hey, look at that.
I will say that we've had to make some changes. Sanitarian is a very unique skill set. And technically sanitarian, you're required to have a master's or a registered sanitarian, which means you can inspect a variety of things such as anything from well water to food establishment to swim pools. So we, in order to increase our applicant pool, we're starting to post it as like investigators. It's an easier fit because in DC, we don't really need that skill set of inspecting well water and things of that nature.
Right. Okay. All right. So we're moving along in the right direction. I am a little alarmed that only 55% of the school cafeterias were inspected, given how many children eat food that's produced in those establishments. Why isn't schools considered high level like hospital?
I'm sorry.
Or I wouldn't call them a
So-
hospital, but you know, like in higher.
But it's the way the food is prepared. So most of the food, they're not actually cooking it at that particular school. Most of it is prepared, and all they're doing is warming it up.
Okay.
So the higher risk levels are the things which go through the danger zone multiple times. So and what we consider a danger zone is from 41 degrees to 135. So when you're with bacteria, think of bacteria like people. They need certain conditions to grow. Every time you heat up and cool down the food, bacteria grows. So the more time it goes through that cycle, the more bacteria grow.
Okay. All right. So when new schools open and you guys are doing the checklist and sort of giving them approval, et cetera, I'm assuming that the school is communicating whether or not they're cooking on site versus they have a contractor who's delivering it.
Correct.
Okay. As part of the food inspections, do you all also do inspections of shelters?
We do inspect some shelters, not all of them. So yes, so like DC Central, yes, we inspect that.
Okay. Okay. I don't have any remaining sort of short questions, so I'm gonna yield back my time. Councilmember Parker?
Thank you.
Thank you.
I am going to pick up on food access. There's been a lot of conversation on the council about expanding access to food in the district, namely through SNAP. And there are several other initiatives that I want to just dig into to get a better understanding around how the agency is supporting the district and ensuring that more residents have access. Let's first start with the medically tailored home delivery meals program. And this, let me ask you, can you just frame what's the goal of that program at the agency?
Sure. So the goal of that program is to ensure that individuals with chronic conditions can have access to foods that are appropriate for their dietary needs.
And where do the referrals come from on who to serve?
Healthcare providers.
Healthcare. And is there any vetting, or is it a matter of if someone has a recommendation from a doctor, they are able to participate?
They could qualify. So primarily patients with diabetes and other chronic conditions like that would qualify.
Okay. And how are you measuring success for this program? And what I'm getting at while we are bringing up someone else, and if you could share your name for the record, I'm not sure if you've already shared. I just want to underscore whether or not the programs that are underway are working towards the goals that are stated. And because we're putting a lot of money towards a lot of different initiatives, and I just want to know, how do we know if we're being successful? So.
Good morning. My name is Sarah Beckwith, and I serve as the Bureau Chief for the Nutrition and Physical Fitness Bureau, and the Interim Chief for the Cancer and Chronic Disease Prevention Bureau. Medically tailored home delivered meal interventions have a lot of research behind them to show that they are effective. They are costly, but you are providing tailored meals to a high-risk group of patients. So we measure success in terms of with our grantee Food and Friends, looking at household food security, if they are able to meet some of their chronic disease self-management goals, and if they come to a point that they don't need the services anymore.
Thank you for that. That is, and I'm a big fan of Food and Friends, as
Yeah.
I know many of us are. And that is helpful. I want to switch gears to Produce Plus.
Mhm.
And if you can frame what's the goal of that program?
Produce Plus is a nutrition incentive program that reaches individuals that have lower household incomes. So they qualify for SNAP, TANF, WIC, Medicaid, and provides $40 per week through the months of June through November to spend at farmers markets.
Yep.
So the aims are to increase access to fresh produce, but also to support the local economy.
Awesome. This is going to get into the weeds of the numbers and the
Okay.
pre-hearing response. So the agency's response has said there were 11,396 individuals who were enrolled, or more importantly, there were 3,817 people that were waitlisted. In
Mhm.
other words, there's not enough money for them to participate in this program. Do you all have an estimate of what would be the operational cost to ensure that we can enroll those folk in the program?
We do not at this time. I believe that grantee Food and Friends had estimated maybe around $2.5 million.
Okay.
But we would need to do our own estimates.
And what I'm getting at there is, I'm glad that we were able to cross the finish line with SNAP enhancements in
Mhm.
this upcoming budget. If there are individuals that need these additional enhancements, let's fight for those as well, because based on the survey responses, it's pretty clear that this is a successful program. Not all of the pre-hearing responses provided survey data, but this one did. I wanted to also ask about senior hunger.
Mhm.
There is a bill, no senior hungry law. As of today, it has not been funded. But can the agency talk about how you're coordinating with the Office of Aging and/or other agencies to address senior hunger in the district?
Sure. Looking even at Produce Plus, we partner with the Department of Aging to help refer seniors into the program. And we also serve as a lead agency for the Age Friendly DC initiative. So we lead Domain 8, Community Health and Support Services. So we have a collaborative of agencies and we meet on a monthly basis. And that includes the Department of Behavioral Health, Department of Healthcare, Finance, Department of Aging, Department of Parks and Recreation. And so we have a set of goals and objectives around increasing access to support services. So that includes food, DPR, senior activities, the PACE program for all inclusive something.
So-
And so really that is an example of agencies coming together and really trying to support each other
Mhm.
to implement these interventions.
I appreciate that. I have some follow-up there, but well, let me ask this. For the programs, some of which I've already highlighted, through those coordination meetings, are you all triangulating? We have these individuals who are in need of services. We have these individuals who are taking advantage of these various programs and seeing who's not taking advantage of perhaps programs they're qualified for and or maybe
Yeah.
they don't know about.
Mhm. And I also think that the Department of Aging would be a great agency to ask those similar questions. We identified a need that we need to get more seniors enrolled in SNAP.
Yes, yes.
So DC Health, we've partnered with the lab and the Department of Human Services to support DHS in their simplified application for SNAP and to increase awareness among seniors.
How many, and it's fine if you don't know the answer, but how many pages is the current SNAP application?
I don't know that number off the top of my.
Last I checked, it was like 50 something odd pages
Mhm.
compared to Maryland that I believe is like 20 pages, which is still a really long form, but I'm glad to hear that you all are working towards trying to consolidate that. But there are many barriers that exist. And we'll connect it to that. What other efforts are underway to expand access to the SNAP program and making sure people that are eligible for the program actually are able to take advantage of it?
And I don't want to speak on behalf of the Department of Human Services, but I know that they do have a contract for outreach. And so they contract with DC Hunger Solutions.
I'm sorry, I through either those coordination meetings that the agency is part of or other initiatives that
Sure.
the agency is leading, what efforts are underway?
So at DC Health, we lead the SNAP Ed program.
Yep, I was coming there next.
Okay, great, which is the education arm of SNAP.
And I see there are many recipients of grants through that SNAP Ed program, Howard, American, et cetera, and the list goes, UDC.
Mhm.
Outside of them reporting activities that they're engaged in, how are you measuring success that individuals are actually taking advantage of the program and or making healthier choices?
We use a number of different qualitative and quantitative methods. We do pre and post surveys at the beginning of like our 12-week classes. So we measure both change in intent to make healthy choices and then actual behavior changes. So are you eating more fruits and vegetables in a day? Are you shopping with a grocery list? Are you engaging in physical activity every day?
Okay. Has there been any thought to incorporate health providers in that survey process? While I trust people are giving true data and information, I wonder if people's perception of what is healthy actually is healthy and leading to the outcomes that we desire. So if I'm eating a microwavable bag of something that has a lot of sodium, perhaps I think I'm eating healthy when in fact it's not. So my understanding based on the pre-hearing responses, it looked like much of the data is self-reported. Are there any efforts to get professional or health provider inputs into people's nutritional decisions?
Just want to dispel the idea that people don't lie to their doctors. Let's let that go. It's always self-reported.
I didn't use the word lie.
They do.
But I do think
I just
people.
less than health for many years.
I do think, and I think this craze about vegan food, for instance, there are many people that would say, I'm eating healthy because I'm eating vegan. And then you look at the ingredients and it's a lot of processed foods, a lot of sodium. So what one perceives to be healthy may actually not be healthy.
Usually we are not asking people for their opinion. Usually we're asking them for a memory of how many vegetables you ate, usually we're trying to get objective data that only they know.
Understood.
When we are trying to find out how people are judging their behavior, and we need to know that too. So what do you think your level of health is? Because that tells me whether or not people should be seeking care, whether or not they think they need education. There's only so much you can do for somebody who doesn't believe they need your service. So knowing who believes that is helpful. So it's not, because it's self-report doesn't mean it can't also be objective. We don't have a way to check it necessarily, but they also are the experts on what they're doing in a way that probably no one else is.
Okay, I'm over time, but I do wonder if there was a survey of nutritional experts that could weigh in to give data on the program and whether or not we're truly meeting outcomes. That might be worthwhile given the amount of money that is going towards these various efforts. But thank you.
Thank you, Councilmember Parker. I'm gonna pick up where he was on healthy food. So I was so happy to see that our participation in the WIC program increased in FY23 to a little over 12,000 individuals, which is really, really great. And some of the most effective measures included improving customer service, making the website mobile friendly, making it available in Spanish. Is DC Health looking at these changes as a model to help improve customer experience with other parts of the agency?
We are. So it's we can share these best practices across our other maternal child health initiatives, as well as any of our chronic disease self-management initiatives.
Okay, so WIC's Farmers Market Nutrition Program experienced a significant increase of participation, over 150% after rolling out the electronic benefit option. How are we learning from this success? And are there other areas where we can push for more increased participation in WIC?
This was also a great example of a partnership with a community-based organization, Dreaming Out Loud. And it took a couple years. WIC Farmers Market Nutrition Program across the country has a history of being underutilized. The benefit amount is not an incentive. So you receive $30 per season.
Per season, not
Yes.
per month.
Per season. So many of our market
Okay.
double that amount. So that's the one of the challenges that you're working with. Like, how do you encourage, especially families with children who have high social needs, to spend to take the time to, so Dreaming Out Loud, and it took us a few years to get the model to where it was really working, have a home delivery initiative. So families were able to spend their benefits online on the Dreaming Out Loud website platform, and then have the produce delivered to their home. This year, families told us, we don't want to have to be present at the time it's being delivered. We want to have that option because we've got other places that we need to be. So we put in place a lot of different quality improvement.
So it sounds like you were listening to the recipients of
Yes.
the program and trying to adjust
Yeah.
in that way, which is great. I having that additional context of the benefit, right? Like, we are more generous in our Produce Plus program than WIC is with their farmers market program, which might explain why our Produce Plus market program has been doing better than the federal benefit.
Produce Plus is a locally funded program, so we have a lot more leniency, flexibility.
I just like $30 per season.
Yeah.
Do you know how much a tomato costs at farmers market? Like, what? You buy 2 tomatoes and, well, okay, I'm exaggerating. But the point being is that, like, one trip to the farmer's market and you're done. So you would go in June and then that's it.
And that's like the maximum amount set by
USDA.
But we're also trying to build behaviors so that families go to the market. And then we're also encouraging families to spend their SNAP benefits at the market. So
Okay. So DC Health speaking of farmers market, but DC Health had underspending on the USDA Farmers Market Promotion Program grant. We only spent about 31,000 of the 431,000. And in the responses, you all explained that it was because of unredeemed vouchers. What's the change here? Because we know that demand for farmers markets exists. So why are there so many vouchers that went unredeemed in this program?
And I need to get more details on that. I know that that was a grant that was, it took us time to get it loaded into the diff system.
Okay.
But yeah, if I can get back to you on that.
Okay, great. Okay. That was on food. Let's talk a little bit about the public lab, the public health lab and some data reporting. Okay. So CPPE reports that they aim to publish the 2021 and 2022 data on the behavioral risk factor surveillance system in February of 2024. Can you all provide a copy of that once it's published to the committee? Okay. Are there any high-level trends or findings that you could share today? It's okay to say no, but considering it's next month, it's 2 weeks.
I know. I haven't reviewed the report as yet.
Okay.
It's coming up the chain, so I don't want to misspeak. But there is a Burfus stats web query that is up to date with 10 years of data up to 2022, and I can send you the link. It was in our response.
Okay.
But it's interactive, and you can do a lot of manipulate or slice and dice the data that you want, but that's currently available.
Okay, great. You also wrote that, not you, but your team, also wrote that the mortality dashboard with data from 2016 to 2021 will be published in January.
Mhm.
Again, 2 weeks.
Yeah.
Will this be the first time that this data is publicly available?
On a dashboard, yes. Otherwise, it's always in a report.
Okay, and
we're-
so what led to you all making that decision to change how you
So
release it?
We're still going to do the reports, but we were trying to be more timely in releasing data. So we were trying to think outside the box. And so it's going under review right now. And as soon as we have our checks and balances, we hope to publish it on our website.
Okay, great. So when asked about the length of time it takes for DC Health to transfer federal funds to the Public Health Laboratory, which for the public, that sits in another agency, the Department of Forensic Services, CPPE responded that it did not have a robust internal tracking system to identify the amount of time between when DC Health receives the funds and when it's transferred to the Public Health Lab until Q1 of FY24. So what's the current system for tracking the length of time for funds to be transferred?
So in full transparency, we have developed a tracking mechanism using Microsoft Excel, and we have been making sure that all the funding from our electronic lab reporting capacity grant is their line item inventory. So we are now trying to make sure that what's the public health lab and what's been approved is now tracked in that system.
Okay, so
This
have
is
we
one of those-
transferred any funds in
I
FY24 yet?
Yes.
Yes, ma'am.
Yes, okay. All of them?
No, ma'am. We have, there's another tranche that will be, is being finalized this week with them. And that will maybe treble the amount we've transferred so far for the year.
Okay.
So at least we still have to go through the accounting process, but at least they will know what's coming and the MOU would be finalized. And so at least that piece they would be aware of.
Do you guys have to establish an MOU every new year?
Yeah, yes, ma'am.
That's how it's
Yeah.
been done. This is an area that really does need some performance improvement. I think both sides acknowledge that. It is very high on the list. We cannot exist without the public health lab. We need them to function.
Yeah.
So it is an area I'm very concerned about, and we're going to spend some time on.
Okay, great. It's, again, I sit on the Judiciary Committee, so when I go and I talk to Dr. Diaz about, hey, why hasn't this group spent their money? And then they're gonna say, well, DC Health was sitting on it. Like it, everybody, if in these types of collaborative relationships where you guys are the pass-through or the federal home, we gotta sort of communicate better. So I'm glad to hear that you guys are gonna be working on that. Last week, we heard from a public witness about the reports for death with dignity. And that DC Health hasn't published the report from 2021 or 2022, even though these reports are actually quite short. I think like 3 pages, and that includes a cover sheet. So why we have this delay on this particular reporting, especially given that we are getting some unwanted attention from Congress on this particular issue. I'd like for them not to think that we're hiding something.
Understandable. Actually, that report is published on our website. It was going through final review at the time, and the public witness has been notified of that as
Okay,
well,
great.
so that he has that. At times, some of the delay with that reporting is the reconciliation of the data, because we have to verify information with our vital statistics department. We also have to verify with sometimes with the actual physician and the pharmacy, because just because someone has dispensed the medication, we can't take that to mean that they actually ingested it. So
Okay.
we don't, the part of our house of DC Health that produces the report, we don't have privy to all of that information. So there's a lot of checks and balances because of the critical nature of that information that we want to make sure that we have right before we issue that.
Okay. All right. That's good to hear that you guys publish that and let Mr. Mulhauser know. So thank you. I don't have enough time to get another question off in a minute. So Councilmember Parker?
Thank you. I want to come back to 2 HOSTA-related questions. One related to pre-hearing question 25 that inquired about audits completed during fiscal year 23 and 24. There was one that I wanted to get better context for. And my apologies if you all have already talked about this. But the U.S. Department of Health and Human Services issued a corrective action to the Department of Health for the HIV Emergency Relief Project grant. Can you describe the issue and the corrective action posed? Okay, no worries. And while you're doing that, I guess I can give some background. But the U.S. Department of Health provides the DC Department of Health, the HIV Emergency Relief Project Grant, or HIVER, I believe is how it's referred to during fiscal year 2022, based on budgeted percentages. The percentages were entered into the PeopleSoft Human Resources payroll system.
It's about time and effort reporting?
Yes.
Is that the one? Okay.
Yes.
So that is a repeated finding that we had actually throughout the agency. But we have implemented a system now where we verify time and effort quarterly. And we actually had a site visit from HRSA in November, and we received a compliment on that and how we turned it around quickly.
Nice.
And
You
that
didn't put that in the pre-hearing.
Well, it's about the previous fiscal year, but yes, so we have we have corrected that and we received a compliment.
To
from
make
HRSA.
sure I'm tracking though the issue, the Department of Health receives, let's say, a block of money,
Mhm.
and you all were paying individuals from that grant line without saying what percentage of their day-to-day work related to the services?
So we always have to report and budget by percent of FTE that is contributing to a grant. What they wanted us to do was to go back and ensure it, like every pay period, to ensure that the person, if they were 0.5 on a HIVER, as you called it on there, and they were 0.5 on local, that we went back every pay period and made sure that
And
they
represented
worked.
what percentage?
Right, 50% on HIVER and 50%. And so we set up a process to do that.
And can you
across the
detail what
agency.
that process is now?
Sure. So we receive a report from our Office of Grants Management of everybody who's attributed to the grant that I supervise, for example, with their effort on each grant. And then I report if that is accurate or inaccurate. And if it's inaccurate, we go through a process at that time to change or update the allocation to the grant. If it's accurate, we attest to it and certify that and send that back. And then if it's inaccurate, then we get another report to verify that it was corrected.
But it sounds like this has already been corrected and we've even gotten some compliments, which is
Yes.
good. You may not be the right person, but there was also a corrective action for immunization and vaccine for children.
That's not.
Can you? Can you?
That might be the same finding, you know, sir. That might be, that finding goes,
Got it.
it's
the
that's
same issue.
Yeah, it has to do with how you budget and then how you end up spending. So that's the finding we've had across the agency for eons. And
Okay.
that solution we've implemented now across the agency.
Got it. So you would say that too has been resolved?
I would say that has been resolved. It's extremely labor intensive, but it has been.
Got it. Okay. I'm going to switch gears on a more macro level, talking about pandemic related issues and infectious disease. Can you give the high level accounting of where the district stands now with the COVID-19 pandemic? And I put pandemic in air quotes because I don't believe it is recognized as a pandemic in the current date, but
No,
where are
we're
we
in a
today
different stage.
relative to where we were just a couple of years ago?
So at this stage, so there's the macro and then there's specific answer. The macro answer is that COVID's considered endemic. It's just circulating like flu and other things, and it will rise and fall sort of the way all of viruses do, kind of periodically. Specifically, we have seen some increases. I always like to be sure that the average one is the same for everybody, and it is higher for folks over 65, and there are some racial differences. So there is certainly some parts of the community that are having a harder time with COVID than others. Our vaccination rates for the newest vaccine are really low. They're equivalent to the rest of the nation, better than some places, but they are very low. So we don't have reason to believe we have a great level of community level immunity. At the same time, though, we have not seen significant increases in hospitalizations. Those may be delayed. We may see some increases, but we have not as to date. We do have some increases in wastewater, which are concerning, and we watch. That's sort of a general whole community measure. So everybody ends up in the same place. So we know that we have a high burden, but it has not resulted in severe illness so far.
And can you detail what steps the agency is taking or has taken to prepare for a future pandemic? And this was a question that came up last year in terms of how are we using what we learned to prepare for what might potentially come next?
Well, one of the first vacancies I filled was the director of our Health Emergency Preparedness Response Administration. We did some things in COVID that are kind of best practices for all time, sort of involving community and things like that. But specifically being ready for the next emergency is going to involve preparation from that administration in terms of how well prepared we are to pull in staff to do things immediately, how healthy and communicating our health and medical coalition is. So that's our collection of hospitals and other providers who meet on a regular basis to be sure that they're all prepared and talking to each other. The test of that is just the other night when we had the boil water advisory. The advisory came out. A few hours later, they were all on the phone, the hospitals and nursing homes and others who were affected, to hear about it from DC Water. And that is our HEPRA administration that arranges that kind of thing. I think we're going to keep our tight coordination, which is really important to be sure that hospital capacity, that all of those things are monitored. Our data is going to stay I think a high level goal that we be able to have that kind of real time data. We're in discussions with all our data sources to try to enhance that so that we can see things coming and that we don't have to stand up whole new systems to be able to tell what's happening, but we can just change the way we ask the questions. So I think we are in many ways light years ahead of where we were at the
Mhm.
start of COVID. I think we can turn the data on very, very quickly. I think our staff, we've already done one whole staff training. We're going to keep going, having a whole agency response where everybody's prepared that what their role might be in the next emergency. And we, I think, are growing a good team in terms of who's going to coordinate that.
And lastly, I know we had a stockpile of tests and PPE equipment. Where are we with that today? And I know kudos to Chairperson Henderson, who was trying to work and coordinating with different communities to get some of those tests out. I know many residents, especially as we are in now winter months, would appreciate more access or even just having knowledge of what might be available to them. So tests and other PPE equipment.
So we did start planning probably in October about how we were going to do the preparation for this season to try to make sure everybody was equipped. We did a couple of things. One was distribute tests through the school district. When you have any concentration of folks, that is one of the times when, even if it's not affecting that group, so even if the students in that school are not a problem, they having a big increase will then drive an increase in the rest of the community. So we asked voluntarily for kids to take those 2 tests home and test themselves after vacation before they came back to school. Those did get distributed for the most part. The school district was quite involved in that conversation, and I think that was coordinated well. We put more tests available in libraries for the last, I think, month or so. So they have a regular resupply that they're doing from our warehouse. We are regularly resupplying from the federal government. I think at the moment we have about, I think last count was 100,000 tests. We are, just last week, I had a call with all of the long-term care and they are setting up a regular resupply to be
How
sure
many
they have.
tests are you having to dispose of because they've expired?
So the expiration dates were extended on quite a lot of the tests. Because they were put out fairly rapidly, the expiration dates are probably not as solid as they might be on an older
Got it.
product. So we did get additional months to use all of those, and we've used many of them. To some degree, it depends on the community who's getting it, whether or not being able to explain the expiration date is okay, even though it looks like it's expired. So it wasn't something we gave out to everybody, but we did use quite a few of them. Do you want to comment anymore, Keith?
Okay, thank you. I have 1 minute. Let's see if I could squeeze in one more question. I'm going to jump to the Howard University Center of Excellence. There was a significant amount of money allocated for that program. If you can give a 10-second description of what that funding was meant to do, how would you describe it to the public?
So a center of excellence is meant to develop best practices and both deliver a higher level of care, a higher coordination and higher level of innovation in care than a normal just clinic. And it's meant to develop those best practices as something that can be spread.
And overall, would you say the program has been successful to date?
There have been areas where they've made some substantial progress. In sickle cell, I would say they've made substantial progress and actually built something that will change practice. There are other areas where they have not done the hiring and building yet to be able to do that. And we've been trying to transfer between those.
For instance, where would you highlight?
I'm going to let.
I'm now
Thank
at
you.
time.
Senior we talked about this a little bit,
Yeah,
but I think it's a legitimate question.
Yeah,
So
we did talk about this a little bit, but at the women's health COE as well as the behavioral health COE, we don't feel are actually rising to the intent of what we want them to do at this current time. But we've been working through areas to opportunities to reallocate some of the funds that have gone unspent in those areas to support the more successful COEs on oral health and sickle cell. And we're continuing to provide technical assistance to Howard on how we can strengthen their work plans for the other
And I'm looking at a
COEs.
table that
Hmm.
details the amount awarded versus expended.
Mhm.
Why the discrepancy there? Is it because they weren't successful in certain areas, so we didn't pay them?
So the first year, they did not spend anything. And then I think it was the second year, we were able to establish a non-lapsing fund, so that some of the unexpended funds could roll over to a future year.
In fiscal year 23, we only expended 48%, some
Yes.
$6 million out of 12.5 million.
Yes, only 9 million has been expended thus far.
And why? Why the discrepancy there?
There's just been significant challenges that they've had with staffing up their COEs, getting their
I got
infrastructure.
you. So the issue is with them and their ramp up versus.
Yes.
Okay.
yes.
I
And
have
if-
more
oh.
questions here, but I want to respect the clock and I'll come back to it. But
So I'll
yes, you have.
also add that I think the first 2 years were supposed to be allocated towards infrastructure building. So the fact that they got behind in that piece definitely set them.
Do you
back
know
for
the
future
reasons
years.
for why they say they were behind?
It was mainly the staffing as well as supply chain issues. And then,
Gotcha.
yeah, so,
Okay, thank you.
sure.
Councilmember Parker, you should go visit the Centers of Excellence. It's on Howard's campus. A nice building, although I think they were moving offices. So there's that. We went on a field trip because we had questions too. So field trips are good to let people know what's going on. Okay, I want to switch to health professional licensing. So the committee has confirmed 17 nominees for health licensing boards over the past year, which is we're moving along, but I still feel like we have a large vacancy rate for our boards. And we're also noticing that for many of the current folks who we just did, like literally, 3 weeks ago, their terms are set to expire like in April of this year, which means that like we're going to be back at this again. So I'm just curious, what are your all's conversations with the Mayor's Office of Talent and Appointments to make sure that we can get all of the boards staffed up, and that we don't have these long holdover type of situations?
So we meet with the Mayor's Office on Talents and Appointments, our liaison. We try to meet with the person monthly. There has been some staffing changes. So we are working with Ms. Williams so that she, as far as reconciling all of the boards, so it's 19 boards with various memberships. So we meet with them monthly. Traditionally, in the past, we've worked with the boards to work with MOTA to ensure that they know who is on the board, who's coming up for reappointment. If individuals, typically our board members do us the courtesy of informing us first if they're going to resign, and then we work with MOTA to let them know. Some of our board members, if they know that they do not intend on being reappointed, also volunteer to act as a holdover until a replacement is found. So I work with them in that space, also working with them to have them know who's licensed. I know that they've upped their engagement as far as their recruitment. And again, a lot of our standing board members work to also help us recruit in the sense of they tell their colleagues, and that's kind of how we drive applicants to their website for positions.
Okay. Can you all provide the committee an updated chart of the seats and vacancies on each board? And I recognize that we're going through the HORA, and so there might be some consolidations and whatnot,
Yes,
but
we
we
have.
just want an updated situation. And I know that you don't control this full process. I think we had one nominee who testified before the committee a couple of weeks ago, and she said she had first expressed interest and applied like 2 years ago, and she finally got through the process, which doesn't help, right? If somebody is standing up and saying, yes, I'm ready, and then it takes us forever to go through the paperwork. That also being said, I think there are 3 or 4 nominees who the council just approved, who their stuff expires in April or May. Go ahead and resubmit their paperwork. we're not gonna hold another hearing, but let's just get it going so that we can actually be timely on that front, if possible. Okay. So Bill 25-312, the Health Professional Licensing Board's Residency Requirement Amendment Act, becomes law tomorrow, January 23rd. So as you guys are sort of percolating on ideas, this is now a new opportunity, a new foray of you can, if they're licensed here, but they don't live here, this is now an opportunity on that front. And so we'll ask in March or April. I'm not entirely sure when your budget hearing is, but like, let's just say this spring, to just get an update on how you guys are sort of moving with that new flexibility, which would be great. So at last week's hearing, we heard from the Dental Society that recertifications, they report went quickly and smoothly than previous years. So they had praise. So yay, kudos to the Board of Dentistry team. However, the overall application licensing timelines increased between FY22 and FY23 from an average of 28 days to an average of 46 days. How would you explain this increase?
So the increase came about due to our criminal background check requirement and the process. So before, our interpretation of the law that requires the criminal background check was that we were able to issue a renewal while the results were pending. And then if there was a positive hit, that we would address it on the back end. We were advised that our interpretation was incorrect, and that in order for us to issue or grant a license, we have to have the criminal background check first.
Fully
The
completed.
results, yes. And so that is the delay. So now it requires that staff manually go in and review the results and then approve the renewal. And so the renewal, which really sets us up for being timely, would in the past would take the day you applied. If you did not respond in the affirmative to any of the screening questions, or that you owed the District of Columbia any funds, you would automatically get your license. So that was counted less than a day. Now the renewals are being added because it might take, the criminal background checks are taking anywhere from 3 to 7 business days to get back the results. So
Okay.
it's taken an average of 10 business days for us to issue someone's renewal from the date that they submitted.
Okay. Are you all communicating to applicants that there has been a change in the process, right? Because for some of them, they're like, last year or 2 years ago, it
Yes.
only took 48 hours and now it's taking 2 weeks. What's going, DC
Yes.
Health, what's going on over there?
So notification went out when we were advised by legal about this change.
Okay.
That happened in April and May of 2023. And then we also include that notice in every renewal notification.
Great.
Because we are encouraging individuals to apply, renew their license sooner than later. Don't wait until the last day of the deadline to submit your renewal application. So that is included in every renewal notice. But 3 different notifications went out in 2023 regarding the change to our
Okay.
stakeholders.
So maybe this can explain some of the professions who saw an increase in processing times from before. So for instance, well, did nurses recently renew?
So different factors. So the LPNs renewed mid-year in 2023. At the end of 2023, it was our NAPs, so our CNAs, HHAs, and TMEs.
Okay. And what about psychologists?
Psychologists are currently going through their renewal, so they all renewed at the end of or the beginning of FY24.
Okay. It was, we saw the increase. It was an average of 3 days and then it went to 88 days. 88 is a lot. I think for someone made the recommendation, maybe it's not you guys, but someone out there has made a recommendation that people not be allowed to submit incomplete applications.
So we've made that, we've also made that recommendation. I think some of the issues with that for us is kind of layered. In order for an application to get started, you know, they have to have somewhere to send the documents to. So for us, if we're getting a transcript, but there's no application on file, there are still things that are primary source, as they call it. So they have to come directly from the issuing institution,
Yeah.
such as your transcripts and your exam scores.
Okay. Okay. In the FY24 budget, the committee funded the High Need Health Career Scholarship and the Health Professional Loan Repayment Program Amendment Act of 2022. Do you all have a timeline for implementation of applying those scholarship funds to folks who are applying?
So the High Need Scholarship Program, we are currently in the process. We're actually, I think, conducting interviews today and Friday for the program coordinator for that, for the High Need Scholarship. And then we have a framework in place that the staff has worked out and designed. And then we're working with legal to draft the regulations related to that. So our goal is that we would be launching this hopefully at the beginning, I would say, of FY25 to be realistic as far as ensuring that the programs identify the students and they get the funding.
Okay. DC Primary Care Association testified last week of the need for certification for community health workers. In your pre-hearing responses, you all said that DC Health considered this, but there was a disagreement about whether certification should be voluntary or required. Have you all reconciled the internal debate?
So it's not really an internal debate, it's a debate with the external stakeholders in DC Health.
Okay.
DC Health, in our opinion, as the Health Regulations and Licensing Administration, we don't license or certify or register anyone optionally. It is if we are gonna draft regulations or create legislation for it, it will be a mandatory requirement. So we are going to pursue it, and it's going to be a collaboration between the Health Regulations and Licensing Administration, CHA, and HOSTA, because they utilize community health workers in their programs.
So it's a certification, not a full licensure. It's not, what's the other option that you have? Registering. So there will be some type of educational something.
Yes.
Okay. All right. So I guess I can see why some of the organizations would feel like that it would be a hindrance for folks. Okay. But what board,
So
where will this like
so we
sit?
have currently the structure that we're thinking of, it will go under the Board of Social Work, but I think it still needs some teasing out. I think when you use the title community health worker, some of them are in the space where they are supporting all vulnerable individuals, right? Some of them may be working with people who have terminal illnesses versus the ones that work with individuals with mental health issues, and they typically call them community support workers. But as of now, they would be housed under the Board of Social Work.
Okay. Okay. Pivoting to long-term care in my last little minute here. What's the timeline for the rollout of the medication aid training for home health aides?
So it's really the examination process. We're in the contracting space. So the application is built out, the regulations are there. It's that in order for individuals to get licensed, they have to take an exam. And we are working with the testing provider to solidify and finalize the contract so that we can then begin offering the license type.
Okay. Last week, the representative from the DC Long-Term Care Ombudsman testified that Hurler's model discharge plan had not been updated for 15 years. Do we have is this on the radar for update?
My colleague is coming up.
Okay.
Short answer, yes.
Okay.
We actually have already started. I think because of some staffing changes on the ombudsman side, as well as DC Health in regards to counsel for Office of Health Facilities and the ombudsman, there were some starts and stops. And we have finalize, I think, the last recommendations that the ombudsman provided to us. The law requires that we collaborate to develop this model discharge plan, which is a tool. It's not a requirement that any
Mhm.
other providers utilize. And so when we last met, and I think we met sometime last year. So we've met about the plan a couple times. And they've given some responses of some things that they want, and we've, given some things that we want. And so our goal right now is to re-engage with the ombudsman to present to them what we feel should be the published document, and go from there. So our hope is that that will be finalized, definitely by the spring.
Okay. All right. Thank you. I'm over my time. Councilmember Parker?
I'm gonna give this a go, and I anticipate the response. So pre-hearing question 15, in cases where you have been dissatisfied with procurement processes, what have been the major issues?
I've done a lot in 6 months. I have not done a lot of procurement, so I'm gonna let the COO answer that.
And I'll share why I'm asking this in a second.
We work closely with our contracting staff. We met with the head of the contracting, the Office of Contracting and Procurement
Yes.
in, was it November? Nancy Hitman and her team in November. And I think there's we have a very good working relationship with them.
I trust that you do. But what challenges are arising given that partnership?
I wouldn't say they're challenges with the partnership. I think there are ways that the district operates that
Yes.
could make things a little bit easier.
Give me some
I think that the
examples.
anti-deficiency law is a big thing. I say
Say that one more time.
the anti-deficiency law is a big thing. Regardless of how aware you are of money that is coming, if there isn't, and there's a need for that, and if there isn't a valid document there that says it's there, but so far you can take the process.
Mhm.
Their processes done with the right intention. So you have to make sure that there's complete transparency and there's a willingness that sometimes maybe the partner that there is some awareness that may not be able to provide the services in full, but you must still make that available to them. All done with the right intent. So is there a problem with the relationship? I think not. I just think that in the best intent of how the district operates, there's just some things that happen that could make things easier.
And how, I hear you loud and clear. And how are those systems impacting the programs through the Department of Health?
It takes a lot of coordination to minimize the impact. We have an example of, so we have these successes all the time in the department that you wouldn't even hear about. So Aisha talked about something a couple minutes ago with respect to the high need scholarship program. We had internal discussion in the Department of Health about 1.5 years ago. I think when we talked about bringing this forward, no money was identified for it. But the program, we moved forward in developing an application, working with the partners, working with the schools, working internally to develop an application with the intent that this will come in October. So it takes the relationship with the contracting team to be aware that we can have these discussions. It doesn't violate anything when the official procurement comes out. We have to work with the finance team to say we want to post a position even though funding doesn't become available until October. So there are ways that we work around some of the limitations we have in the district, staying within the confines of the law.
Understood. And related to question 16, if you could wave a magic wand it's related to what we're talking about, but if we could improve systems, practices, in order to make more efficient the programs that the agency is overseeing, what might be top of your list?
I think our response was none. But I really think there's a small procurement. I think there could be more flexibility given to subject matter experts within the agency, for example, to make a determination that this may be a direction they want to go with this particular
versus
having to go through
benign approach of who bid the lowest. And
and then what we've realized is that we have We have very savvy,
Yes.
very savvy places. And so sometimes you are entering into a position that you can foresee, but
Yeah.
you can't avoid it because of some of the.
It was kind of a lead-in question. I knew that must have been a challenge having had an opportunity to work with OCP. Because when you have subject matter experts, they know more about projects and what might make for a best contracting practice given the context at hand. So thank you for that. That is really helpful. I did want to switch gears to vaccines, and I think we've already touched on this. I know we talked about the COVID-19 vaccine and the rates, but I wanted to come to school vaccinations, where roughly a quarter of DCPS and charter students are non-compliant.
Historically,
Historically,
not anymore.
where are we today?
Right now, we have about 3,000 students across our key grades, which is pre-K, kindergarten, 7th and 11th grades that are non-compliant. Overall, we've made a lot of progress with kindergarten coverage of MMR vaccine. So we're, I think, currently at 88%.
That's
coverage.
huge.
Yeah.
That's huge.
Major
And
improvement.
what accounted for that shift?
The push to really have kids vaccinated. We did a lot of community engagement. Schools were very much engaged as well. I think focusing in on the key grades also made it more manageable, right, for us as well as schools to really engage with families.
And I'll come at this two different ways. One, as expected, wards 5, 7, and 8 are among the lowest compliance numbers that we see here across the city in terms of school vaccinations. Is that still the case to date? When that is based on data that I have from fiscal year 23, wards 5, 7, and 8.
Yeah, no, we've made significant improvements across all wards.
Okay. And then another trend that I'm noting is that high school students continue to lag behind significantly everyone else. Is that still the current trend?
They are still lagging behind. You know, we're seeing that as it relates to HPV as well as the second dose of the meningococcal vaccine. So one of the things we'll be exploring with our ed sector partners is how we should really handle that second dose of meningococcal vaccine. The goal is to really prevent vaccine preventable diseases, right, and assessing the risk. We are seeing good coverage in terms of that first dose of meningococcal vaccine.
Okay. And is there any guess why the second dose is not being taken up at the same rate?
Well, we see it across the board. There's a little less engagement with the health system in general for that age group.
Yes. Yep. No, that rings true.
Just want to point out, some of this is that people are late, not that they never. So we want them to have it when they're due, and they are not getting there. But if you look at the eventual number, it's not that they are never getting it. Our numbers look better by the end of high school, but they're not. And that's true for the kindergarten, by first grade, and it's that people are delaying, which is leaving them open to risk. But it is not wholeheartedly that people are not engaged at all.
Okay. Okay. Just touching on the COVID vaccine again briefly, it's important to note that in wards 5, 7, and 8, we're seeing the lowest vaccination rates, and among African Americans, we're seeing the lowest vaccination rates. I think some of that might be fatigue. I think there was also some mixed messaging, or I should say mixed understanding of the benefit of the vaccine. I take this vaccine, I won't get COVID. And then people say, oh, wait, no, I could take the vaccine and I could still get COVID. And I can just say anecdotally from conversations I have with people, they're saying, well, if I'm going to get COVID regardless, I'm not going to take any more vaccines. That's not an endorsement. But if you wanted to give a PSA around the benefits of getting the latest dose of the COVID-19 vaccine, what might that be?
It is, when people are stressed, they think in black and white. So I understand why we are where we are. But it is possible to have a little bit of COVID, maybe not a little bit pregnant, but you can have a little bit of COVID and a whole lot of COVID. So people who are not going to the hospital, which is what we eliminated really with the vaccine, is the folks who were, I mean, we all remember from the beginning of the pandemic, people were in the ICU for weeks. Some of them went home forever changed. People were disabled in a significant amount. Not having that happen anymore is an incredible, really, victory for public health. For whatever reason, that gradation of you still might get a headache and a cough, but that's not what we were trying to prevent.
Yeah.
That message has just not gotten across because
that's
people
right.
have that COVID in their mind as that major thing. And so it's either that people feel fatalistic because it's either I'm going to get it or I'm not, and they're thinking in black and white, or I do think a significant of this is just fatigue. People are just, they want it to be over.
They want it
Please
to be
just be
over.
over.
Don't we
And
all?
when you're telling me about another vaccine, that's not over.
Yep. I see time ticking. One more question on the school nurse issue, and full transparency, I'm interested in addressing some of these loopholes through legislation. I know we had talked about a need potentially for a date certain when health suites need to come online. Do you have any data, or can you follow up with data around how many health suites were requested over the, let's say, the last 2 or 3 years between October and May of what I'm trying to get at is the burden that you all expressed was that in the middle of a school year, as new schools are coming online, or perhaps a school is relocating and they raise their hand and say, oh, now I want a health suite, that then puts the program in flux. And so I know you may not have that data offhand, but it would be helpful to know how many school requests you are getting during the school year.
Right, so I'll say we're making significant changes with the program overall, right? So one of the things is the timeline at which we may put out the RFA for this program, the timing of which people are allowed to apply for their school health suite to be part of the program. And so we want that all to be aligned with the budget, which
Yes.
means the cutoff is going to be in springtime of each year moving
For
forward.
the next school
Right,
year.
right.
But do you have that data around?
We do, I just don't have it off the top of my head.
Understood. If you could follow up that,
Yes.
even
Yes.
if you could do it for the last year, that would
Yes,
be helpful to
yes,
just have a snapshot of how many requests you're getting.
But we have a few schools that were already planned for this school year that were in the pipeline that we're still considering. There are some other schools that will be receiving notice that they will have to wait because we're trying to make sure we're fully staffed up with the amount of schools that we've already accounted for.
Okay, so maybe we don't need legislation. Understood. Thank you. Thank you.
Okay, so Dr. Bennett, we've been going for about 2.5 hours. Do you want to take a break? Take a 5-minute break and then we'll come back and we'll finish, which will probably be like another hour and then we'll be done. Okay, great. So we're going to take a 5-minute break and then we'll be back. Thanks. Okay. All right, guys, we're almost there. I think we got like 3 or 4 more areas to cover. I want to make sure that all of you great people who came, every one of your administrations gets some love, because that would be unfair of me to just focus on one. So we've got a couple more folks left. Unfortunately, where's Robin? I still have some questions on chalk. Come on back. You all do so much. You do a lot. A lot. I want to follow up, or I guess pick up a little bit on the conversation you were having with Councilmember Parker. So, sort of in the COVID, flu, RSV, just stuff that we're currently dealing with. We have been receiving a number of emails from residents requesting that we institute a mask requirement for in hospital settings again. Now, there are 2 district hospitals who have already reinstated it. We've talked to the hospital association, and some others are considering it. They're going based off sort of how they kind of feel-ish. And I'm just wondering, what metrics is DC Health using if you're making a recommendation to the hospitals around whether or not to institute it or not? A couple of weeks ago, I had to go to Children's, and the folks in the waiting room weren't wearing the mask, but all of the staff were wearing the mask. So it clearly somebody thinks that there should be a mask on. Even the security officers had masks on, but we're not communicating that to the public.
So I had a conversation with all of the hospital CEOs to see where we were. And then with all of our long-term care providers, because those are the 2 areas where I'm most concerned. I do feel like we are in a not bad place at the moment. Most of them have instituted the requirement in the highest risk areas. So ICU, oncology, and never did relax that requirement. The requirement for staff is not happening everywhere, but at least the strong recommendation and tracking of staff is happening everywhere. And most are doing some strong recommendations and offering. They do not necessarily want to get into a mandate situation. There are good reasons for that.
Yeah.
And we're not in a high enough risk level for me to be advocating that we do a legislative or official emergency recommendation. So to have the power to tell everybody what to do, we'd have to be in an emergency state,
Right.
which we are not in. And I don't think we're going to get there, but we are making efforts to make sure that everybody's on the same playing field. I do think that's happening in long-term care. They are having some outbreak issues that we've responded to, but for the most part, where they can, they've been fairly consistent about masking, at least on the staff level.
Okay.
It is a little different because people live there. So it's a little different for them on some of them in terms of what people's freedom to live their life is.
Mhm.
But I think everybody's aware and monitoring and using the data appropriately.
Okay. I think for the public, I would say, right, when I walk into a hospital and I see all the doctors wearing masks, then I'm like, oh, okay, I'm gonna put a mask on too, because they're in that environment all day. And I think that's interesting. Like, people are only asking it for it in medical settings, and they're not talking about going back to universal masking for all. But I just wanted to ask that question.
Well, I'm concerned about medical settings too, because people who are vulnerable, the elderly, disabled, they have no choice but to go there.
Right.
So they can go to a different grocery store. They can go at 8 a.m. There are other things they can do. It is very hard to mitigate their risk there. But personal masking does work. The vaccine does work. So we're not in the same situation we were 3 years ago, where we had virtually no tools, where that was the only tool in the box. We have lots of tools. And I think we're in a more nuanced time than we were before. And a lot of this is going to be about personal protection based on your own calculus of what you need.
Yeah. Okay. So you talked a little bit with Councilmember Parker around what's happening in the schools around immunization rates and things like that. I want to change a little bit. We haven't made much progress on the percentage of students with medication action plans to manage their chronic conditions. So the chart provided in the pre-hearing responses, only 15% of students with asthma have an asthma action plan on file. 23% of students at risk of anaphylaxis have a action plan. 72% of children with diabetes have a diabetes management plan. How can we improve this? Particularly on the asthma front, that's the one I'm really confused on because families know what the risks are. They know they will end up at Children's needing to get the breathing treatments and all of that. And so who should be doing this outreach? I guess this goes to, because some people will say, well, if there was a full-time school nurse, but I'm not saying that, but you know what I mean? Like who should be having these conversations with families?
It's all of us. There's a couple things we're trying to do to attack this. One, to make it easier for those action plans to be completed and tracked and sent to the right place. Making sure that we can also move to more electronic systems as opposed to paper forms. So we have made progress in the first phase of the EUHC project, but there has not been significant utilization among providers that would have to submit that manually to us right now. But the next phase is to continue to work toward making sure Cerner and ECW, the major electronic health record systems used by our hospitals, are able to submit that data electronically into our school health management system. We're still working through that with those providers, those vendors, and working with Children's on that as well. But we're hoping to make some progress through the fall.
Okay, so on that, you all have noted you've made some progress on the electronic system for universal health certificates, but it will not be fully completed until the end of 2024. So does that mean for school year 24-25, I'm going to be submitting a paper form to my kid's school again?
We are hoping that we can get the vendors to work on a more expeditious timeline with us.
Okay, it would be great if we could launch school year 2024-25 and parents not have to send in the paper.
That is our goal.
We're going to put that positivity out into the universe and we're all going to hopefully work on that because I think that could help a lot in terms of getting our numbers up, but also just streamlining like the paperwork that we have to continue to submit over and over and over and over again. And it could also help, I think if you guys switch to electronic system, then other parts would also do so as well, right? So in the process of signing up for summer camp, they require the same form, so we use it multiple times, but all right, I'll go on that. I want to switch to opioids, which kind of falls in the child arena, sort of.
It falls in quite a few areas, none of them exclusively,
Okay.
but there's a little bit in a few
Well,
areas.
so let me say this before you go out. I was very impressed with CHA's framework for improving community health. And I think it could be a model for how the district can set specific goals, metrics, report on them annually, and what is our progress towards them. Like it was a very clear, and we're working on these, I think it's 6 or 7 things. Here's our tracking for it. That was great. Y'all should take that on the road show because it was just very clear to know what you all are working on and how you're doing it. I would love to see that model applied to opioids.
Yeah. So I don't think I hold most of the metrics around this, but we do hold some. I will say that what undergirds that specificity is continuous process improvement. So that is an approach that we're trying to move to everyone. They have a very strong program in CHA. That's how you have data quality, you have folks who are looking at the metrics, and everybody's trained on what you do when the metric's not what it should be. So that's what the Chief Performance Officer is going to try to be spreading into the rest of the department. We do have a role in opiates in terms of being the folks who hold a lot of the data, especially the data integration. So we are trying to tell a story about what could happen with the data in terms of being able to identify people, to follow them over time, to decide what some of these risk factors might be for people to have worse outcomes than others. We don't have all of that data, but what we do have is enough to set some goals in terms of what we want to happen in terms of people's entry into treatment and other things. But the goals would be done by other parts of the city. So they would be goals for FEMS, they would be goals for DBH. There are
Right.
only so many things.
Which
that
is
are goals for
fine.
us.
There are so many people who touch it. I just feel like we should have some goals.
I think that approach of having a goal and then having people know what to do when you don't get your goal, should be everywhere.
Okay, I'm foreshadowing for everyone else in the health cluster whose hearings are coming up. I'm gonna ask about this because you all have parts. Deputy mayor, DBH, healthcare finance, everybody has a role here, and I think that this is part of that. Now on the data front, I understand that you guys are compiling a data inventory for opioids, aggregating the current data available, identifying what's missing, et cetera. Do you have sufficient resources to fully implement this project?
There is some further integration and coding that we could do. Some of it we already are doing, so we're doing what we can. There is some additional coding that we're trying to do. I'm not sure how we can do that during this fiscal year. And we have some improvements are in the budget for next year.
Okay, so CPPE reports that it will be publishing the DC State Unintentional Drug Overdose Dashboard in February of 2024, which will include a comprehensive data on unintentional and undetermined intent drug overdose deaths collected from death certificate and medical examiner reports from 2016 to 2022. Okay. How will this dashboard be different or interact with the data inventory that you're already planning to do and the surveillance reports that OCME puts out every month? I imagine you're all using the same information. So I'm just trying to figure out, how will the CPPE information be different than what OCME already develops and puts out?
Some of that what's developed by OCME is also us. So,
okay.
So yeah. The point of a dashboard is to allow people generally to manipulate the data to try to answer their own question. So I'm hoping that it does that. Where we are looking at past information, other than just a surveillance report of what's happening at the moment, what you're looking for is what's the trend? Is there something that we did at a point? Is there something that happened over time to see what's changed over that time period? So I do think there's some value in being able to string all of the years together rather than just looking at, this month, these are the places where we're having problems.
Okay. Councilmember Parker, I just have one more question on in the opioid space. So in the pre-hearing responses, DC Health reports that it's adding 7 new harm reduction vending machines for its grantees. Am I correct that this would increase the total number to 13 across the district?
It's 14. Yeah, it's 14.
14. Okay. Okay. Now here's where the complication comes in. So my understanding is that the Department of Behavioral Health was paying for the vending machines.
Yes.
Through SOAR dollars. So,
and the new ones also.
And the new ones also.
They're not paying further. The first 7 are paid for through EHE funding and then the HIV epidemic funding.
EHE, emergency health.
No.
Ending the HIV epidemic funding.
So they are a HOSTA intervention around HIV.
That we've added.
That we put Narcan in, we put
Fentanyl
we
strips.
put other things in them.
There's a lot of things.
Holistic for the people who we're trying to target.
Okay, so how many have you all paid for?
We pay for the first 7.
Okay, and then who's paying for the next 7?
That's the DBH SOAR dollars.
Okay. Okay. What's the demand been like?
To date, there've been over 4,000 items dispensed. They haven't even been active for a year. There were 3 that came online before the other 4. And so we've seen a higher demand at the one on Atlantic Street in Southeast. That's been the most used one so far. But we do see an active demand for them in the community, and we've received positive feedback about the ease of use of the machines.
Even with the code situation?
Mhm.
Okay. For the first 7, did we use local dollars or grant dollars?
Grant dollars.
Grant dollars. Okay. I was just trying to make sure we're sort of keeping it straight, because when people are saying like, we need to increase the number of machines, great, that's fine. But if there is SOAR money available, then we shouldn't spend opioid abatement settlement funds to pay for the vending machine. Does
Yeah.
that make sense?
We are
Or-
not. We're using SOAR dollars.
Right. So I think we just kind of I want to get the buckets clear of who's
Mhm.
paying for what, because I don't actually think a lot of people know writ large in the public that the original 7 came from you all and started as a HOSTA initiative. And then we added Narcan and other items to it. Okay.
Well,
ahead.
they had it from the beginning.
I was gonna say the Narcan's been in there.
It's
from
been
the
there from
beginning.
the beginning.
That was the strategy behind the use. Intravenous drug use is the way the HIV is spread. And so things that we can do to decrease the risk of HIV hepatitis being spread through those terms, as well as decrease overdoses, increase access to fentanyl strips and all those things, is what the intervention was.
So trying to be full service for the folks rather than to look at the population need, rather than try to just
Pinpoint
give
one
a-
thing.
Yes, do one intervention. It's got lots of things, hygiene
There's
products,
socks, yeah,
other,
hygiene products.
and
COVID
bringing people
tests.
in because they needed one thing and then they see the other things that are there.
Mhm.
It really is a baseline intervention that has lots of potential to do other things.
Yeah. And we're tracking in terms of evaluation and success.
Mhm.
Because, the other end of Pennsylvania Avenue, they're trying to prevent us from doing the needle exchange.
Mhm.
We already know what happens when
Yes.
we can't, because we evaluated that last time. But I think it's always good to just remind those folks that like, we know a little bit of what we're doing.
And some of the machines do have syringes in them.
Yeah.
Can I just update the language that we use for syringe services programs and not needle exchange?
Oh, sorry. Yes,
Mhm.
syringe services
Sorry.
program. I will do better. Okay. Councilmember Parker.
This will be my last round of questions, and I'm going to jump around a little bit, but I want to pick up on the opioid-related questions regarding the community health worker certification. Broadly, what does DC Health see as its role in addressing the ongoing crisis?
The opiate crisis.
Yes.
There are a few things. One, we are the source of the analysis for much of this data. So in terms of where things are happening by location and who they're happening to, we're taking in data from all sides. The OD maps, other things are DC Health interventions. So that's the first, to be able to characterize what's happening. And I'm hoping we move that to why it's happening. So in terms of being able to track people over time, being able to see specific treatment centers or others and where people are more successful. That's
Quick
going to take
follow-up
some
there.
different data.
The health index that will help with that towards the reporting on the why, or no?
I think that you mean the health opportunity
Yes.
index. It will help us in terms of what the burden is in any particular area. Looking at the cause and effect is going to take some trend over time.
Got it.
We really will have to look at individual people and try to compare them to people who had a different outcome.
Got it.
So we will do both. What I'm hoping for from the data is that we can enrich that part, since it is a significant part of what we're contributing. We're trying to do some improvements. We're talking to healthcare finance and trying to figure out what additional data sources we can bring in or what additional things we can do with the data we have. So that is an active project. Our other intervention is really about the workforce that's available to do this. Some of the, so the addiction counseling and those other things, having a sufficient number of those people, our health careers and other interventions that are attempts to increase people in these various professions. That is one thing that we can contribute to this, is being able to have those people available. We don't always have the different kinds of peer groups, peer counselors and peer navigators that are out there are not all classified as community health workers truly. Some of them do have an actual certification that's already existing. So being able to professionalize this so that people can actually get paid and feel as if this is a career path is something that I think we are contributing.
And I noted in your responses, while some think it's best to keep this certification optional,
Mhm.
the agency thinks it should be a requirement once enacted.
So we're the regulator, but that is not the only way in which you determine whether somebody's qualified for something.
Understood.
So there are, accreditations that could happen. You could just use a graduation requirement for a degree. So if we want to regulate it, meaning we keep track of how many there are and we have a quality baseline for them that we as a city are setting, then we need to do it as a non-voluntary thing that we regulate. But you can just say, we want to use one of the national standard setting organizations, and people are only going to hire people who've been in that organization, or we're going to have a curriculum in our providers of the education that's going to meet particular standards. So
So-
it's not the only thing, it's just, we are the
So to
hammer
double
and it's
tap
nail.
on timeline, because I noted in the response, it seemed like there was some ambiguity in terms of timeline for the certification
Mhm.
that you all are noting, the process leading to it is at a standstill. Can you give us estimate when we might see that type of certification?
So I would say it would take about a year in order to stand up any type of license, certification, or registration. Again, a bill would be introduced so that we can professionalize that group. Regulations would have to be drafted, and then having our application process. One of the things that we're discussing internally is a determination on if we're going to handle it internally or if it would be outsourced by a third-party vendor. But to start the process, there needs to be legislation
So
saying
you're waiting on us.
that, yes, you want to have the community health workers be a licensed, registered, or
problem.
certified profession. in
And the
district.
reason why I'm underscoring this is because we've heard about the importance of the certification from the community, especially those most impacted by this ongoing crisis. And so I will commit to working with Chairperson Henderson on advancing that. But it sounds like you were already working towards it. Was the pause with a appreciation that maybe there should be legislation mandating this versus the agency taking it up on its own?
So there's been a couple of things. So there was a bill introduced previous to, I think, many of us in the room regarding the community health worker or community support worker, and that bill did not go anywhere. And so DC Health kind of had paused on it. About sometime last year, maybe in late 2022, early 2023, the external stakeholders engaged in the conversation, and there was meetings back and forth kind of to say, how do we want to proceed? And then most of the conversation, we were at a standstill because they were going back to their group about our requirements, which is if we're going to move forward with regulating, it has to be mandatory. It's not.
I got you.
Yeah.
So just to put a pin there, you all are awaiting legislation to move forward with the certification process.
Yes.
Unless there's some strategy
Other than that.
That is super clear. Thank you. I'm going to try and squeeze in a few other questions. The Health Opportunity Index, I know you have it projected for June of 2024. One, where will this index be published? Will it simply be on the website? And what are the plans for the index after June 2024?
Yes, we will publish it on the DC Health website. The goal is to have something that is tangible for everybody to use both inside of DC Health and beyond, just so that we have a more granular comparison across the district about what is driving health and how we might focus it. We have noted what is being done in Virginia, where they've used it for other things, but we have not kind of gone to that stage yet, just to kind of project exactly how it's going to be used here.
And what I heard from Dr. Bennett is that in the long run, perhaps we can then track trends and maybe use it for more
Absolutely.
informative methods.
I think what we have started to do already in the work that we have done over the last 3 years at in the Office for Health Equity is to kind of be a little bit more granular about populations that we want to focus on at the sub-ward level. And that has been some of the work that we've done in the health disparities and health literacy work.
Okay. I'm going to switch gears. So the Elderly and Persons with Disabilities Waiver Program, or EPD waiver program, I know it's not managed by DC Health, but instead DHS and the Department of Healthcare Finance. However, it is my understanding that DC Health issues the license for different programs. Is that accurate? Or let me ask it this way. What is DC Health's role within the EPD waiver program? And I'm going somewhere with this.
Hi.
Hi.
Our role is to we license the healthcare facilities. So we license the assisted living facilities. They then, if they choose, can apply with Department of Healthcare Finance to become an EPD waiver facility.
That's right. So DHS is responsible for qualifying individuals for the program. DC Care Finance funds different facilities that are part of the program, and DC Health provides the license for the facilities.
Yes, they don't have to become an EPD waiver program. They come to us to get a license as a assisted living. And then if they choose, they can become an EPD waiver, but it's not a requirement for assisted living.
So in full transparency, and I'm not going to go into the details now, but I have heard of a concern of a specific individual that had a relative that had a pretty negative experience with a licensed facility, and has had challenge getting a response from DC Care Health Finance as well as the Department of Health. And so 2 questions there. In addition to, I would like a commitment that you all will follow up with this individual to investigate what is going on at this healthcare finance or healthcare facility where their loved one was in the EPD program. One is, do you have any data around reports of negligence and/or harm caused in these facilities? And if so, can you share that? And I know you may not have that off the top of your head, so you may have to follow up with that. And then 2, how are you investigating the licenses of these facilities when these concerns are raised? So 1, do you have the data? And then 2, what do you do about the license once a concern has been flagged?
Okay, so our survey reports are public on our website. They're posted on DC Health's website under assisted living. So the reports are there for that. Specific information regarding specific care areas that if you would like that type of information, we could follow up with you specifically, for instance, if there were citations related to care or
so a specific individual in a specific facility that has a license provided or authorized by DC Health, there are allegations, sometimes lawsuits forwarded against said facility. What I'm getting at is how is the agency evaluating whether or not that facility should maintain its license?
So we conduct annual licensure surveys for all of the healthcare facilities as required by regulation, as well as complaint-based investigations. And so once we receive the complaint, it's reviewed and triaged and assigned for investigation by someone from our staff. We conduct unannounced visits. Those, they don't know that we're coming, and we communicate with them while we're on site with the provider. So they're very much aware of what our concerns are. And then we also issue a written report to them. That is the report that I'm referencing that's on our website. And then they have to respond to us within, I think for assisted livings, I think it's 15 calendar days. They respond to us, letting us know what their actions will be to remediate that issue that we've identified and also ensure that it does not reoccur. In addition, we do have authority to issue notices of infraction and take licensing action if we deem necessary based on whatever the deficiency is. And so that could
And
be
is that on the website too?
the licensure action.
The notices of infraction?
That's in the responses that we provided, and I
Okay.
believe it's also posted on our website.
Okay.
But
I
if that's
must have
not, we
missed
can
that.
provide that. If you provide the name of if you get with us
If
and let
it's
us
in the
know.
responses, I will get it. But and Councilmember Henderson, if I could just have
Yeah.
2 additional minutes and then I'm done. But for this individual, who would be the right person to put them in touch with?
That would be me.
Okay. So following up today's hearing, I will make sure that we connect them with you. And while I know you and or the agency may not be able to provide them the answer that they want or the response they want, at least they can have some accounting for the situation involving their loved one.
Yes, most definitely.
Okay, awesome. And I'm going to end on what I think is a high note. And I just want to generally ask from last year, what you think, Director, is the most instructive high point or win from the agency that you're taking into this next year? And if you need time to think about it, I'm stalling. We could also think of perhaps an instructive low point or something that you want to do better. Okay.
I'll give you a high point. It's
Yeah.
the most that always kind of trips me up. Because there are a bunch and judging between them is hard. So I think that the work that's happened in CHA around moving on some of the primary care quality issues so that we are getting people to have their hypertension treated. We are getting people to have lower their hemoglobin A1C. So I think that that really concrete work has been a high point, as has the perinatal quality work, which is essentially a similar process of identifying a problem and then checking to be sure that we've actually solved it. Getting some technological improvements in our data in various sites, I think has been important. In HEPRA around how we are able to use some of the data. We're still learning that as we have a new director in that area, but I do think that the process we're going through and the amount of capacity that's been built is going to be a positive that we're going to see the fruit of in this next year. And then last, I would say that there are a whole host of best practices that are happening in one part of the department. We had our all hands meeting, which is we did emergency training. But the other thing we did is do some innovation awards where we're doing something in one site that I'm hoping we'll start to spread this idea of we're doing something in one area to try to move that to another. And so I really am impressed and hopeful by how many new ideas people are moving forward. It is very hard in federally funded programs to have new ideas, but the staff's been really creative, braiding funding, using local funding for small pilots, and then moving it into the permanent funding. So the innovation of these little improvements around how we contract, how we deliver a service, how we use delivery for something, and when we know we can't get a grocery store in that area. So that kind of problem solving is happening everywhere. And I think it's really it already has borne fruit, and I think it will continue to.
Awesome. I like what you did there. You kind of squeezed in 4 or 5 things. No, which is great, which is great. But the reason why I wanted to end there is I know sometimes these hearings can unearth what's not working. Right. Why are we not doing this? This isn't as ideal I do know there is a lot of hardworking individuals within the agency, and you all are doing a lot of good work. So I'm glad to end on that note.
Thank you. I appreciate that.
Thank you, Councilmember Parker. Okay, I have like, I have a hodgepodge of things to get to. I'm gonna go back to long-term care.
Okay.
So we heard from the DC Alzheimer's Association about several requests for more responsiveness from DC Health. So the first, as you guys know, the DC Alzheimer plan has not been updated since it expired in 2019. We heard that there was a draft, but that it hasn't been released. What's the estimated publication date for this?
That's your answer.
That one will be ready in the next month. It's in the
Yeah.
final stages of review and edits. It's almost ready for release.
Okay. So February, March. We'll come back to you in March.
February.
Okay. Okay, last year, DC Health stated it would finalize the regulations for dementia training for direct care workers in FY '23 so that the program could be implemented. What's the status of rolling this out?
I'll start and then I'll see if my colleagues have anything else to add to this,
Okay.
but we've been working on drafting the scope of work for the vendor to take on this training. We plan to offer a training that's web-based, that is free to participants. And then we're working with our colleagues in HRLA to establish the legislative component of that.
Okay, I think we gave money to DC Health in FY '24 for this. So this training needs to go live in FY '24. Yeah?
Yes. Yes, so that is the plan for it to go live in FY '24. So we have had several meetings with CHA as well as with stakeholders to try to identify vendors and things of that nature, but it will go live.
Okay. We were thrilled to see that DC Health has launched the public awareness campaign on brain and memory health for several months in FY '23. Are there plans to continue this in '24 or in the future?
Yes, we've also received some additional federal funds that we plan to use towards the campaign moving forward.
Okay. All right. So the Board of Nursing data from this is about long-term care, I promise, even though I'm starting with Board of Nursing. But the Board of Nursing data from January 3rd shows a sharp decline in direct care workers. So home health aides, about 1,700 fewer. We got about 2,300 fewer CNAs. This is concerning as we have an increasing aging population, and particularly residents who want to age in place, but they might need assistance in doing so. What do we think these numbers mean?
Yeah, so we do typically anticipate to see only about an 80% renewal rate, and that's just due to retirement, moving, things like that. So typically it's made up in the initial licensors, that 80%. But it means it's a shortage. It's a shortage not only where we're at now, but also in the pipeline. So in the schools.
So if we have this shortage, then why haven't we made moves to extend the flexibilities that we had during COVID that allows for folks who are CNAs but licensed in Virginia and Maryland to continue to operate here in the district?
So we have made some of those moves. Unfortunately, a lot of it. So we have done a couple of rounds of extending like the bridge program to go from one to another. A lot of what we've seen is a lot of people who have not taken advantage of it. Some things which the long-term care community have asked for, we are not in a position to do.
Is that because it's not your agency and it's healthcare finance? So for instance, one of the things, they want a minimum wage increase.
Yeah, correct.
Okay. But have you all shared the Board of Nursing data with the Department of Healthcare Finance to underscore like, no, this is about to be a problem. Like we have to take some active steps, proactive steps here to bolster this particular workforce? or we're not gonna have folks.
So we do meet with healthcare finance monthly. And we have discussed about the shortage. A lot of it came around the time when the overtime funding stopped.
Yep.
So we have had discussions with them, as well as we've met with the long-term care community several times within the last couple of months.
Okay. So what's the resolution? I know it's not all you, so,
So what we've been trying to do on our end is we've been trying to negotiate with both Maryland and Virginia with reciprocity agreements.
okay,
We already have something in place for the Board of Medicine, but specifically for nursing, we've been trying to negotiate with them on reciprocity agreement. So for example, the one with the Board of Medicine, it allows them to get licensed much easier and much quicker because we already know what Maryland needs, what Virginia needs. So for instance, if they have a license in Virginia, typically all they need to do is get a CBC in DC and they can go ahead and get their license. So we've been in those negotiations for several months now with those two jurisdictions.
all right.
And we do plan on expanding it, but we just wanted to start with the local jurisdictions first.
Okay, so how can we accelerate our conversations with these jurisdictions to land the plane?
So the NAP group is a very unique group, and these are the nurse assisted personnel groups that fall in this cluster that you're speaking of, the home health aides, the trained medication employees. And so not all jurisdictions register or certify them. Also, their requirements vary state to state. They have different names and titles. And so it makes it very unique in order to expedite the process. I will say that in the conversations, for example, the Virginia Board of Nursing doesn't handle this group. However, they do handle the group. I'm sorry for misspeaking, but our requirements are not the same. So in order for us to move forward with reciprocity, it has to be determined that there is a substantial equivalence. Maryland had some changes, so we are actively engaging in the conversation. And I know that they're going to bring it before their board to determine if they would want to, or if they feel like what we require in the district is substantially equivalent to what they require to see that partnership can merge.
Okay. Offline, not here. It would be interesting just to know what are some of the differences in.
Yeah, it's like different names. It's like in Maryland, it's like a geriatric certified nurse. And then the training requirements are slightly different, but we have been collecting that data in order to engage in these conversations, so we'll be able to share.
Okay, I'm sure we'll have more conversations about it because you guys know I introduced a direct care workers bill. Don't worry, it'll be in March. And I think this is a growing issue, especially as we have a growing aging population. And going on that, so, you know, I introduced a transparency bill for assisted living facilities. And then shortly thereafter, there were lots of new licensure survey reports and complaint findings that were published on the DC Health website. And so I don't think this is you. I think this is you. I'm just curious, are we on track to do a more timely reporting thus far? Because we had a 3-year window where we didn't publish any of these survey reports or any of the complaint data on the website. And now we're publishing a bunch right now. And so going forward, are we going to be on a timely clip?
Yes,
Okay.
that is our plan.
Okay.
That is actually one of the strategic initiatives for HRLA for this year. One of the things that we have been looking more at our reporting and making that information more publicly available. One, to our benefit and for the public, because we recognize that if we put more of the information out there on our website, one, we will get less FOIA requests for the information, just being honest. So we are working on that. Some of that also speaks to some of the staffing challenges that we've had as far as lack of administrative staff for the Office of Health Facilities, but we are currently in the process of hiring an individual to be
Mhm.
able to assist with that and some of the other administrative responsibilities that have fallen to some of the supervisors in those programs who also have been also going out in the field
Okay.
and conducting surveys.
When there's an incident reported at a specific assisted living facility, is there any requirement or responsibility that they have to inform the rest of the community of a finding from you all?
The rest of the community, as in,
The other residents, like if it was involving, like, so for instance, um, there is a recent complaint finding that was posted, where a resident went missing, in October of 2023. But the call to you all wasn't made until 4 days later. And so my understanding is that when a resident goes missing, it's supposed to be fairly immediate that they do that. But one, you know, are there any consequences for assisted living facilities not timely reporting to DC Health about some of these things? And then two, is the larger community made aware that this was an incident that occurred?
there's no requirement that they notify the rest of the residents of the
Okay.
facility. For us, the requirement would be that we be notified immediately. And usually that's within about 24 hours that we should be provided notification. And so we would conduct the investigation and they would have to respond to us with a plan of correction, and we would also issue an NOI. Depending on the outcome, we would then consult with our general counsel to see if licensure action, meaning restricted license or provisional license, something of that nature, would be warranted at that time.
Okay. Are these types of complaints common or outliers? Missing residents, failure to update individualized service plans? Those are just two that kind of came up.
They happen. I don't know if I want to quantify how frequently. I think it honestly will depend on the facility and the provider type, meaning versus assisted living versus nursing home. But one of the reasons that we don't only do licensure surveys like an annual is so that we can capture those things. Our goal, obviously, and our expectation is that providers would be in compliance with the laws and the regulations at all times. We know that that's not actually true. And so we do rely on complaints from the ombudsman and ongoing conversations with them because they are often in the facilities as well as residents and family members contacting us, letting us know their concerns. And there are times that there may be concerns that don't rise to the level of needing DC Health to enter the facility and conduct a formal investigation versus it's a breakdown in communication between the individual
And the
and the
family.
facility, or the family and the facility, and lack of communication or understanding sometimes of what their practices and policies are. So one of the things that I tell my staff that I feel our role is to implore upon the facilities that, DC Health is contacted when we feel as the public, we don't have anyone else to talk to.
Yeah.
No one else is listening to me. And that's for all of the healthcare providers. No one usually wants to call us, and because we're sometimes not going to be able to go out that very day. It's a lot easier if you're in the building to speak to the person who's actually, one-on-one caring for your loved one. So having that ongoing communication.
If I have a complaint or if a resident has a complaint, is there a way for them to electronically submit that complaint to you all?
Yes, we have an online complaint system that is on our website that for the Office of Health Facilities, which is our preference. Obviously, we have a hotline as well that they can call and someone will speak with them and take their complaint. But I do encourage family members, especially sometimes residents, if they have email access or online access, to file their complaint online, because
Okay.
I like to be able to get it in their words versus us translating what we've heard on the telephone.
Okay. All right. Thank you for that.
You're welcome.
I need to go back to student health for just a second. So, last week, and even at the the school nurse hearing, we heard from some parents at Amadon Bowen about the bottleneck in demand for administration of medication training. Like the PTA was going to fundraise to like do AOM training for folks, which I don't think is like, PTA should be bake sailing for other things, not for AOM, especially not through an organization I think we know about per se. but the conversations with them raised something that I'm a little concerned about, which is we have students in our buildings way past 3:15, right? If they're there for athletic events, if they're there for after school, if they're there for whatever. And there doesn't seem to be a requirement that anyone be in the building in the after school hours who either A is certified for AOM or B who could provide any sort of first aid assistance.
So those after-school programs are operated by outside vendors that are approved by, OSSI or DCPS or the public charter school. And so each of those vendors that come in to provide that after-school programming have their own requirements that they have to meet, which is separate and apart from what we're doing during the school day for the school health services program.
That's correct. But if a student who has asthma and is in an after-school program, shouldn't somebody be in the building who knows?
Requiring that from the contractors would really be either the district, school district, or OSSI would have the leverage to do that.
Okay,
We don't regulate those programs or really get informed about them in
Yep.
any significant way. But it is not, it is possible to just say, if we're going to sign a contract with you or allow you on the school, you have to have someone with AOM training present.
just,
And we could sort of help with that training, but that they'd have to make that part.
okay. Does the existing AOM training program have the capacity, if we were to require something like that for out-of-school time providers, that they have to have at least one person on every site via AOM?
Probably eventually, but not currently, as we're working
Okay.
through the changes with our school health services program.
Okay, and I'm gonna ask the similar question of DPR,
Mhm.
particularly around summer camp
Mhm.
programs, right? Like,
Mhm.
the kids are there. And so we should kind of know about that. Speaking of medication, so in the pre-hearing responses, you all said that DC Health has already begun implementing the Access to Emergency Medications Act 2023. Thank you so much. Including you aim to get the standing order by June 1 and to execute the contract for medication procurement in May in order to be ready for school year 24-25. Okay, so in the FIS, the fiscal impact statement for the bill, it indicated that DC Health needed a nurse consultant and a program support
Got you.
specialist in order to manage this program. Do you all still need these 2 additional FTs?
Yes, we want to make sure we have the capacity to provide the appropriate oversight.
Okay. And what about the 46,000 to procure the locking medication cabinets within health suites?
Yes, everything that we put inside the FIS, we would still need for implementation.
Including the IT upgrades?
Yes.
Okay. I was just saying, you guys are already moving on some of the things. Yeah. If we could shave a little off the FIS. Just wanted to check. Okay. Thank you. All right. Emergency response. Okay, so in the HEPRA's section, the theme seems to be a lot of delays. So the update to the mass trauma plan is supposed to happen in FY23. That's delayed to FY24. The dashboard on EMS and trauma data that was supposed to be in April of 23. That's now September of 24. The trauma registry report hasn't been published since 2019, and it's based on 2017 data. What's going on? Is this turnover? Is it staffing? Is it funding?
I'm gonna let the new senior deputy director speak in a moment, but emergency, so there are several reasons. Everyone had a diversion of almost all of emergency response in public health to COVID. So there are long periods where, unlike other parts of the department, you could kind of continue some of the work. That is where emergency services went, is to pretty much 100% COVID for a significant amount of time. So that is the initial multi-year delay. We've had a long interim period in this program. And while it was was the first hire I made, it wasn't immediate after the release of the last senior deputy director. So I do think that leadership gap has had an impact, but I will let.
Well, let me ask some more specific questions. I'll accept that on sort of face value. I will say, I think next year we can't use COVID as our excuse for not. Yeah. So a couple of these reports. So the mass trauma plan is delayed because DC Health has decided to move the communications platform for the agency and the hospitals to share information under DC Health when it was previously run by one healthcare facility. Why did DC Health decide to move the communications platform in-house?
Thank you. My name is Sam Hurley. I'm the new Senior Deputy Director for the Health Emergency Preparedness and Response Administration. Thank you for your time today. So HEPRA opted to transition to Everbridge, which is a system that's used by both which is a system used by both HCMA as well as DC Fire and other partners throughout the district, rather than using a platform that was homegrown and built within one of the healthcare systems that we didn't have the capacity to support and manage because it was housed on their internal servers. So if there was a problem, we had to call that hospital's IT department to have something fixed. So that's why we transitioned that. And the reason why there is a delay with that plan is the plan's been drafted. We just have to revise to take out the references to the old communication platform and put in the new, which is seemingly relatively simple, find and replace. However, there's some complicated steps that were added in that plan of you're going to go into this dashboard that's built within that communication platform, that dashboard doesn't exist there anymore and is elsewhere. So we're just building out that transition, and we should have that fully finalized this fiscal year.
Okay. That's good that we have moved it in-house. It is a little concerning that we would have had to go to one hospital. Yeah, okay. Got it. And I would imagine since FEMS and HCMA already uses it, this allows for seamless.
It does facilitate easier communication pathways between the agencies.
Okay, so regarding the trauma registry report, so it was last published in 2019 based on 2017 data. You all stated that you're missing data from several trauma centers between 2021 and 2023. So how do we rectify, or are we just going to have a gap?
A gap is unacceptable. We need to have that data, and we have partnered and reached out to all of the trauma facilities as well as the attending surgeons that represent those departments. And we are already receiving that data now and rectifying the problem.
Great. I like to hear that. A gap is unacceptable in the data. Thank you for that. Okay. This is traffic related injuries, but so that's not really emergency repair. Maybe not. We'll try. So regarding the roadway surveillance data project, Dr. Bennett, I understand that in San Francisco, where you previously worked, it has the gold standard in terms of traffic, in terms of tracking traffic related injuries, combining that data from trauma centers, police, EMS, and hospital discharges. Are you familiar with this system from your? Okay. So in responses, HEPRA, sorry, all the acronyms are coming together, states that it's developing a similar system to be completed in FY24. Is the intent for this to be identical or very similar to the one that's operating in San Francisco?
I believe so. Do you want to speak any more to it?
Yeah, so the system that we are working on integrating within HEPRA is to start bringing in those data sources. I will tell you that likely within this fiscal year, it will not be identical to what they have in San Francisco, as that's taken over a decade of work to get there. However, starting to move the needle towards that step and integrating those different data sources together to make informed decisions about traffic-related injuries throughout the District of Columbia. One of the largest data sets is EMS-related data, couple that with trauma data from the trauma centers.
Okay. HEPRA, you also stated that you're seeking federal funds for the project, federal DOT funds. Is that already underway?
So the federal government increased their spend with the Infrastructure Act. And there are significant influxes of funds to state highway safety offices, including the District of Columbia.
Okay.
And so we saw additional funding under the Safe Streets for All grant process. And we did receive an additional $150,000 award from our partners at the Department of Transportation to help integrate these data sources within the district.
Great. So I take this to mean you're working very much in collaboration with the folks over at DDOT on this project.
Yes, ma'am, because we all have mutually aligned interests.
Okay. See, so for some, in some jurisdictions, their Vision Zero projects or dashboards is housed in their Department of Health, not in their Department of Transportation. And some, there are arguments for why it should be on both sides, but it is good to hear that at least from this project and other things that you all feel that the Department of Public Health has a role in the Vision Zero goals or meeting the Vision Zero goals that we have for the city.
If you look at our top 10 causes of death and really hospitalizations, injury is quite high up there. And so there shouldn't be anything on that list we don't have something to do with.
Okay. I wish we could communicate that more to the public because even amongst my colleagues, they feel like I'm only going 25 over. I'm only going 15 over in terms of what that could do to a body if you hit it.
Yeah, I think the understanding what the difference of each additional mile per hour, and there is good data about how long that hospitalization and how severe that injury is. That is part of why public health needs to be involved, because that's the kind of education that we do. That is not necessarily what transportation does.
Correct. Okay. Our piece de resistance. Animal control. Okay, so Keith knows this better than perhaps you, Dr. Bennett. We've been on a long road in talking about animal control, particularly
There's
about
no way I could not have gotten up to speed on this in this job.
All right. The building. Let's start with that. Or buildings. So my understanding is that you all have started to lease office space in an upper Ward 4 area on Blair. And you've described this as space for an animal shelter. Or no?
Yeah, no. Okay, go ahead. You know that too. That's not.
Did we put that in our answer?
Oh, yeah?
Yeah.
That
came from you guys.
So
6,500.
Blair Road is like a remnant of like 2 years ago or something,
Yeah.
when it was one of the 4 sites selected, but that never materialized. That lease was never signed. So
Apologies for that.
it's
Okay.
very interesting though. It does appear on our fixed costs as a property associated with us, which is interesting,
Yes.
but no, we have nothing on Blair Road.
So you're not paying 1.5 million annually to lease this place?
It would be invisible cost because I've never seen it. Adrena? Adrena just said no.
We paying without knowing?
No, she can't just give a no. She's like, no, I need to give context.
I can't.
Oh, introduce.
the amount. I'm
Yep.
sorry.
It just.
I can't confirm the amount, but I do believe that that property is listed on the list that we get from DGS as part of our budget formulation. So I do believe that there is some cost associated with it, but I can't confirm the amount. I can get the amount.
DGS is charging y'all 1.5 million for a building that y'all don't know anything about?
I can't confirm that it's 1.5 million. I can confirm later today, but I don't have it in front of me right now.
Okay. Does anybody know anything about 6,500 Blair Road?
We are not using that.
Okay.
Not
All
our-
right. Okay. What's that?
We don't pay.
No.
the same space.
Okay. So we're gonna follow up with DGS to figure that out. If nothing else, they owe y'all money if they have been charging you all for a space that you haven't been using but it is attributed to DC Health apparently in documentation. Yeah, so question 19. Yeah, okay, all right, so where are we on identifying a new space?
Oh,
Yeah.
You gotta turn your mic on.
Oh, sorry, ma'am. We have identified a district-owned facility in DC Village. It's
Oh.
Southwest. I think it's the address is for, I can't remember the address. It's
Okay.
DC Village.
Oh, is this
the
by
site-
DC Water
Ye-
in Ward 8?
It's close to where the fire department trains at,
Yeah,
in the new metro hub.
where we used to have our old pharmacy warehouse down there.
Okay, Ward 8.
Yeah.
Yeah.
7, 8.
It's 8.
It's 8.
It's 8.
It's Ward 8.
It's 8, near
Yes.
Blue Plains.
Yes,
Yes.
yes,
Yeah.
yes,
Okay,
yes,
right, all right.
yes.
Okay. So what happens next?
Next, we
You have identified a district-owned facility.
get the appropriate funding to build it.
DGS has already done the,
The just has done
Drawings and the
the
initial-
drawings and everything. We've submitted that as a capital project for 2025.
Okay. All right, so we'll come back to this in March. We'll talk a little bit more, hopefully, about your plans. And then I imagine at the same time that you will tell us what your plans are for the New York Avenue site once your Ward 8 site is complete. Probably need to tear down that building, but
So the district has a site for the men's shelter to be built there. So there's a new men's shelter that should be built on that site as we are moving out. The timelines, we do not know. I don't have the timelines of that. But that's the dependency that we had.
that's what we were told. I don't know if that plan changed.
okay.
Absolutely right. That's
Sometimes we
correct
were
is
told that.
correct.
Sorry, it might not have, it might have. I can ask DHS. Look, my response is that only because there's like nothing there.
There's a facility there that will have to be, there's a facility there.
No, I'm saying nothing there in terms of, there's no metro access there.
Oh,
I think there might be a bus if you walk up the hill to Mount Olivet. Okay, but that's not y'all's problem. Okay, fine. Okay. Several witnesses testified last week about issues that they feel that HRA has been violating the terms of their animal control contract. The first is the first issue came up around providing regularly scheduled spay and neuter services. HRA testified, and you all also state this, that the services are not within the scope of the contract. But after we looked at the contract, it's vague and at sometimes contradictory and never really expressly states what's happening here. So were you surprised to learn that HRA was not providing routine spay and neuter services?
I will have to let my veterinary staff answer that, but I will say, we've been communicating with them because when that incident happened, one of the first things I did was look at the contract, and it is incredibly non-specific. So it's a very difficult contract as the oversight of those activities to use as a standard. So I've communicated that with HRA. They came by and we had a very fruitful conversation. I am very happy that they are willing to concede that the contract may not be what we need and that they are more than happy to bid on a different contract if we want to reformulate it. We are. It's going to come up anyway, but their recommendation to us is that we need clarity and write something different that says more specifically or whatever. And I'm still waiting for them to give me that response to my letter in writing instead of in the meeting.
Okay.
That is my expectation for what they have to say. And I think that is the way forward. It is very hard for me to take a complaint that they're not doing something and do anything about it because the contract doesn't exactly say how much or when. It really is quite vague about requiring it. But I want to just say this particular area has a lot of, it lacks a lot of clarity. because we are overlapping many different things and I think conflating quite a few things.
Okay.
HRA has its own role as a nonprofit. So they have a mission to house and care for animals that is apart from us. If the city went away, if the city had never been here, they would still have a mission. If they did that mission somewhere else, it would still be their mission. So that is the commitment they've made to the public. That is what their donations are for. They have their own commitment. Our requirements under the law, which they are doing as our proxy, are really about protecting the community from danger. So
Mhm.
they're about enforcing around dangerous dogs, not the neglect of dogs, but dangerous dogs. They do neglect, they do, all of that enforcement is ceded to them, not by us, by the federal government. And so we have a set of activities that are actually ours to support. And it is the not just the contract, but the conversations and even from the volunteers conflate it all in a bucket. So animal control about danger, animal care around spay, neuter, and spay and stray animals, and then animal shelter for long-term adoption and other care. Those are three different things, and we do two of them and not the third one. And so we're going to unpeel them
Okay.
and do a contract that's much clearer and says exactly what we want to do and how much of it.
Okay, so we are in 2024 going to be releasing a RFP for a new contract.
Yes.
Okay. When does this current contract end?
The contract has options that ended in September. And right now we have a funding gap from June to September that needs to be addressed, which is not uncommon for this contract.
Okay. So functionally, based
could
on
be June.
funding,
Mhm.
the contract ends in June.
Right.
All right. You all don't have independent procurement authority, and I
We
heard
do
some alluding from questions from Councilmember Parker. Have you all already started the conversations with OCP around has to be a priority?
Yes, we
Okay.
have.
Okay. Did you all have an opportunity to listen to some of the testimony last
did.
week? Okay. One of the things that I'm still thinking about that concerns me is around the allegations of dogs that were designated as pending litigation, not having been walked for 8 months.
Yeah.
Or exercised,
Mhm.
in sort of the general sense. And the ED for HRA pointed to DC's health lack of decision-making on whether the dog should be considered dangerous, as to why these dogs are in limbo for so long. Do you all agree with this assessment?
That we spent 8 months deciding whether a dog was dangerous?
Or
do
what
we-
should be the resolution of
So
said designation?
this is one of those where I think we're conflating the long-term shelter and care of an animal, other than the immediate, this is a dangerous dog or not, we need to test for rabies or not. That is under HRA's nonprofit mission. That is not a DC health function. And neither is enforcing animal neglect law. So
Right, but in this particular case, this animal's case, my understanding is that it's pending litigation.
I don't either. I don't know what you're referring to.
Okay, so there was a public witness who testified, there's 2 dogs at the New York Avenue shelters
Yes.
who haven't been exercised in 8 months because they've been deemed as dangerous, pending litigation. In the dangerous piece, it's because traditional gear is not working. So if they put a muzzle or one of the animals is just entirely too unpredictable, and they have deemed like this is an animal who likely they're not gonna foster, likely not to find a home, XYZ. And so my question to the director was, okay, so what happens in those cases?
Mhm.
Because what you're not saying is that eventually you might euthanize this animal for health and safety reasons.
Mhm.
And they are saying that that decision has to come from DC Health, and that is why there has been no action taken on this animal.
So, Ken, I think we're conflating a little bit. So if they was I'd have to know more about this situation to really comment whether or not this is a stray who they then decided was dangerous, whether this was a dog they removed under our authority because it was dangerous. The situation does matter, because if they are sheltering a dog for adoption that they then decide is not adoptable, that is still under their purview as a nonprofit to decide what they're doing with the dogs that they shelter.
Okay,
It's why
so,
some different shelters have different policies, because it is theirs to decide.
so for an animal that has been, an animal that is under their care
Mhm.
because of of a district government policy, right? You bit someone,
Yes.
you've been removed. How long does it take for us to resolve those particular cases? If you could just introduce yourself for the
Hi,
record.
good up. It's on now.
No, it's on.
Hi, good afternoon. Dr. Vito Del Vento. I serve as the veterinarian for the District of Columbia, program manager for animal services, and executive director for the Board of Veterinary Medicine. With respect to this subject, I think there's several moving parts here. So we as an agency receive from animal control in batches reports of investigations that have been completed on dangerous dog and or potential dangerous dog cases. Okay, so anytime there's an animal or animal on person incident, it automatically triggers the investigation. The investigators from animal control go out, conduct those investigations, put together the packets. We receive those as a batch. Once we receive those, my team goes through those. We look at, they provide also a recommendation as to an animal, whether it should be deemed dangerous, potentially dangerous, or no determination whatsoever because the facts don't support it. We take that recommendation as part of the investigation, but we still follow through with our own research and make our own determination. Once our determination is made, then our recommendation goes to the legal team here at the Department of Health for legal sufficiency, reviewed by them. If they're in agreement, then we finalize that determination. Once that determination is finalized, those determinations are sent back to animal control officers to be hand delivered to the owners. Those owners have a certain amount of time to come into compliance. And it's important to know that whether an animal is deemed dangerous or potentially dangerous doesn't mean that we take those animals away. Those animals can still reside at their residence as long as those folks come into full compliance with what is required for those determinations. When we start to talk about animals that are at the shelter and under these determinations, then we have to factor in, has that animal been taken for non-compliance, or has that animal been surrendered by the owner because they're in non-compliance? That being the case, they're given a certain amount of time then to still bring the property into compliance. And often those folks are long in that process in terms of trying to come into compliance.
Okay.
We know that if an animal is deemed dangerous, it is not adoptable. So their really only recourse is to go back to the owner. And so we do everything we can, or animal control works with them to try to get them into full compliance so that the animal can be returned. Where the real long piece comes in is if an animal has been deemed dangerous, but is also under investigation through humane law enforcement, those animals then have to be held and retained until that law enforcement investigation is completed. Some of those go on for years. So those are two totally different pieces, and that's correct. We have
The humane law piece
contract-
is not you.
That's correct. So we are, we hold the contract for animal care and control. Their independent arm, Humane Rescue Alliance, handles humane law enforcement. So though it resides at the shelter, it is no longer under our purview, and therefore it may last for whatever the time it takes for things to go through the court system. And as you can appreciate, things go through the court system, they can be appealed, and they can be appealed several times.
Right.
Some of these cases drag on forever. It
Which-
is truly unfortunate.
Understood. certainly a similar situation that we have on the human side of things. The difference is these animals don't get to go anywhere.
So depending on how they're housed, and again, they're housed through their independent arm. So that is no longer part of the contract. There are two facilities. There's the government-owned facility at New York Avenue,
Yes.
and then there's their independent facility on Oglethorpe.
I understand that they have animals. They too have conflated the two, right? The animals who are at their facility on Oglethorpe are not just their nonprofit arm animals. They have some of our animals there too.
That is correct.
I think I want to express though, for the public, they don't see this bifurcation. They see one contract, HRA, and DC Health as the contractor, whatever. And so they're looking for you all to provide a backstop of oversight around the things that they are seeing within the facility. So I understand we're going to go through the contract process. Personally, as a dog lover and a dog owner, I can't let this part go. So this is what I'm going to ask that you guys do is ask HRA for an inventory of the number of dogs who are at the facilities deemed dangerous and who belongs to who, i.e. who's there for DC Health and who's there under humane law. How long have they been there? And where are they in the status process? Is that something we can?
Yeah, we certainly can request that. And again, some of these that are involved in these court, battles go on for a long bit of time. With respect to oversight of how they manage those animals, certainly anything with respect to animal welfare, animal care does fall under our purview for animals in the district, across the board. Where we also run into maybe some areas of grayness are that if an animal is deemed extremely dangerous, then they will make the internal determination not to put their own staff at risk. And so those dogs will be in runs, but those dogs may not get the same level of walking exercise and whatnot that some of the others are getting, certainly the ones that are more adoptable. And so it becomes very convoluted and gray area in terms of weighing the pluses and the minuses for both the animal well-being and the safety of staff.
Okay. Are you all still contemplating perhaps bringing some of this in-house?
We are.
Okay. I guess we'll have that conversation more fulsome during the budget process, because if you're going to do that,
Yes.
that will need to be part of that. Okay. And then I would also just like to see a plan B for June.
Okay.
What if for some reason there's not additional funding for this particular contract to continue to the September date that it's supposed to? What happens? Because my understanding is that we have the New York Avenue shelter, but we don't own any of the vehicles. And the staff, while we've provided it to them, the staff is technically on the payroll of HRA, not on DC government. So that's like two big buckets of items that we're in FY24 supplemental, we will need to figure out, which we'll sort of see in March.
So I can happily report that we are meeting with OCP tomorrow on this exact subject, so.
Great. Okay. All right. So we'll check in terms of what happens there. If you just give me a moment, I just need to see if I've missed anything.
Okay.
And then you all can wrap this up. Okay. In a normal situation, I would read out all of the follow-ups now, but we're just going to send them to you as an email, if that's okay. And we'll go from there. I think for the public watching, well, first off, one of the reasons we split hearings is so that if we had tried to have this 4-ish hour conversation. Last week, we would have been there all night. And I feel like we were able to have a more open back and forth here. I also want to, for folks who are like, well, you didn't ask my specific thing. We might have asked it in the pre-hearing responses, which were very thorough and fulsome. So please check those documents on the DC Council website. Also, for a practice of our committee, we've had DC Health before us several times, even already this year, to check in on particular topics. So we don't have to have a more fulsome conversation here and it be a 6-hour marathon type of situation. And so, Dr. Bennett, I want to thank you and your team for your testimony today and for the rich discussion about DC Health's activities. This is only a small subset of the team. And so for those who are watching, I want to say we appreciate the hard work that you all are doing to make the city safe and healthy. And I also appreciate the work that you all have done to address some very specific areas that we raised last year, and we can certainly see the improvements here today. So I'm done with questions for on this. The committee will hold its next performance oversight hearing on Thursday, January 25th at 9:30. We're going to hear the public and government witnesses testifying on the performance of the United Medical Center. For any member of the public, again, who wanted to participate in last week's hearing or this hearing, but weren't able to do so, you can submit written testimony until February 1st at 5 o'clock on the DC Council website. The time is 1:39 and this hearing is adjourned. Thank you so much.